Hello, good morning. Welcome to this third session of activities in this social political program. And today we're going to have the participation of Dr. Marlevis Bello Perez, who's going to talk to us about the experience in the management of the pandemic by HIV in Cuba. Dr. Marlevis is a specialist of first degree on hygiene and epidemiology and has a master in infectious diseases. She has a master degree in infectious diseases by the Provincial Center of Hygiene, Epidemiology and Microbiology from 2008 to 2015. She worked in epidemiologic surveillance for sexually transmitted diseases, HIV and AIDS. She's the head of the Department of Control of Sexual Diseases like AIDS and HIV. She has had several research, like educational intervention on knowledge on sexual diseases in teenagers, stigma and discrimination to people living with HIV, elimination of mother-child transmission of HIV, and assessment of the strategic national plan for sexually transmitted infections, HIV, AIDS in Santa Clara. Now she is surveilling HIV and AIDS. Now I want to have a round of applause for Dr. Marlevis Bello. Good morning. Good morning. Well, I want to thank, first of all, the organizing committee for the invitation to this great event. I feel pretty happy and thankful and very honored to express myself and share the Cuban experience during this Congress. Well, let's get started with our presentation. Well, our public health ministry, together with the greatest direction of our country, started with the first actions to give an answer to HIV in 1983, where we had only surveillance with a population that would be in the hospitals. But it's not until 1986 that we implement the prevention and control program of HIV and hepatitis in the country. We have five key strategies that have been consolidating a vaccination component with anti-hepatitis B vaccine, which has already been, we have patented B hepatitis vaccine, an educational part and an epidemiological part, control of focus, also as well as the part of medical attention. Within the fundamental characteristics of the national response, we have political willingness, we have some budget for all sectors, including health sector, that we know it's not enough, but we have the financial support for the World Fund for HIV. It is also the main feature or specific feature of this national system of health is paramount, not only medical attention, but also the promotion that we have for health and diseases with a multi-sectoral focus. The decision-making process is shared and distinguishes the Cuban program, the intersectorality, and the participation of the community. Summing up some chronological aspects of this national response, we have a maternal infant program of some programs for syphilis and gonorrhea. In 86, we had the prevention program and control program of HIV, and we created the operational group for facing AIDS. And in 1996, we have the sexually transmitted diseases program and HIV program, but we opened the National Center for Sexually Transmitted Diseases, which is the center that educates all the people in this program. We also have to say that in the 2000s, the 5 year strategic plans, we have had three of them. They give us, a guidance on the response plan. We have the universal access to therapy, and we start programs financed by the World Fund. It is also well to say that one of the greatest victories that the system of health had, which is the WHS validation transmission of congenital diseases in Cuba. It was a very strict exercise. We had specialists in labs and statistics and epidemiology and human rights, where we assessed all the involved parts that had to do with the elimination and a review, a 3 year review, where I say that Cuba was able to show the indicators that we had, not only by professionals but also by the civil society. In the part of human rights, they would have their interventions on their own without the presence of professionals, in the medical part of a program where they would be able to express all the needs of that community. Cuba has been recertified with this validation and the conditions in 2017, 2019, and now in 2023. Now we're getting ready for the triple elimination for hepatitis C and for the transmission mother-child of hepatitis C. We have been requesting to be certified last year, but when we read indicators, we had our children vaccinated with hepatitis C. You see, the and indeed, children that were born in on weekends, they were not being vaccinated on Sunday, but on Monday, and they have to be vaccinated within 24 hours after being born. So this is why we were not certified. In 2018 and 2020 period, we introduced the PrEP services in Cuba, in a province which with two municipalities. It was Matanzas in the province that you see there spotted, because it was one of the provinces that had experience in the projects financed by the World Fund with good results, and they also provide us with the treatments, and this is why it wasn't there. Nevertheless, nowadays we have 15 municipalities with PrEP and around 1,000 people with PrEP. Exactly, it's 910 people having PrEP in Cuba. One more moment which is important among the chronological aspects of the national response in 2021, the instruction of differentiated services. They are friendly services where attention is focused on the person, which I will later give you an explanation of these different services for cancer and key population with a high prevalence of HIV. Well, the program of prevention and control of HIV is inserted in the family doctor program, which is anchored in prevention for health. We have a human resources for the response of epidemic with more than 21 family doctors integrated with the groups of the provinces of ETS and hepatitis. We have a surveillance of sexually transmitted diseases, and strength of this program is the amount of volunteers in the response that we have. We have more than 12,000 volunteers for the response to HIV. These volunteers, these civil organizations that actually are now doing some political incidents so that they will be acknowledged as social institutions like the rest of the sectors. We're at different stages. I know that we're going to get it so that they will stop being an informal civil society and so that they will be inserted in this kind of programs. They are in the DHCH network and the network of AIDS. They have representation nationwide and they participate in the decision making, given the fact that they have to do with the implementation of programs, so that they will be also present in the implementation of programs when making decisions. Here we have the human capital that are volunteers. It's around 12,060 volunteers, and within the volunteers we have a network of people that live with HIV. Well, the multi-sectoral response of HIV by the decision of the government, we constituted the operational group in 1986 who elaborates and executes policies for the answer to the epidemic. It's made up by the social sectors, organizations, as well as the civil organizations that participate in the response. This is why we have the focus, the international, intersectoral focus. In the different groups, like for example nationwide it's headed by the Minister of Health, and in the municipalities they have their head by the municipal directors of these groups. For example, have sessions every quarter at the level of the municipality. They have a session every 2 months, and it's made up by three commissions: the legality, communication, prevention, and the communication. Uh, they give the response in the different commissions when they have to give accountability of what they do. It all depends on the level where they are. Uh, so that's the frequency that they will have to have their meetings. See, I'm kind of cold. Cuba has two governing elements for the answer to, the strategic national plans. I had mentioned that we had three strategic plans. We are in the 2019-2023 plan, but we have a dialogue in the country now, and we have to have the presentation of the proposal of plan for the next 5 years in the general law of the program, in the national meetings for the key population groups, and the exchanges among sectors. Only in December we will have this kind of a meeting to be approved by the Ministry of National Health. We have a legal framework that protects the rights in Cuba. The Constitution of the Republic, passed by a popular referendum in 2019, decides that more than 90% of a population in Cuba would participate or participated in the elaboration. 86% of a population agreed with the constitutional text, where we had different articles that have to do with the right to equality, non-discrimination, the integral development of women, and protection against gender violence, the right to health, among others. This law 157, the Family Code, a very revolutionary law that never seen before, and due to the social impact it had in the country, the Law 41 in 1983 that rules everything that has to do with national health, and the Ministry of Health is the ruling entity that has to do with all health services. The 1396 resolution, which is some regulations for people that have HIV and AIDS. So, in this framework of human right protection, among these ruling elements, we have also the gender strategy. In here, we have the gender perspective and right, but this is a document for the national response of 2020-2024, a specific policy to talk about gender and HIV. Civil society in Cuba consolidated as a more important part in the national scope. Civil society is trained in all topics like a professional in health. Besides being promoters, they are counselors in the realization of HIV test. They do not have to go and together with health personnel to have an exercise of testing. They can actually be prepared to run the test, PEP and PrEP. They are trained as managers of gender and right. They are part of a commission of legal orientation. We have this kind of service in each and every one of provinces in the country, and the person that would need of a service will be voluntarily go to the service or maybe come from the differentiated services in the health primary health attention, and this of course helps releasing the person with that preoccupation. We also have a social worker and a psychologist in each one of these networks. And the epidemiological context, Cuba has diagnosed from the beginning of the epidemic up until 2022 39,254 people. It's an epidemic concentrated, slow growing, and masculine epidemic. 8 out of 10 people that are infected are the men, and 9 out of 10 are men that have sex with other men. It's a focused epidemic within two groups. It is concentrated on transgender women and in the population of men that have sex with other men. Here we have the story of a treatment that we have in Cuba. We started with a treatment in 2000 or year 2000. I have talked with several people because they ask me many things, and one of the things that I have said, once we start with the treatment, when the patient had less than 250 cells and less than 500, now we are diagnosing and treating. We give a treatment after the first 7 days. We do not have to wait until it is confirmed. The confirmation of the diagnosis doesn't take more than 7 days, but we do not need to wait. We don't do it nationally, but we do it in every province. Thus, we guarantee that the treatment will be timely within the 7 and 14 days after the test, with the medications recommended by the WHO. For children, we can have a treatment for 6 months, but for the rest of the population, the treatment goes for 2 months only. Here we have the analysis of what we have, the progress in order to get the regional goals. We have 7 years. You can see the main gap that we have is the first pillar, with the knowledge of the serologic condition of a person, which we only get an 83% in this case. We have gotten the second pillar of treatment. We are showing an indicator of 96%, and even though we have advanced considerably in the viral suppression, as you see the bars in the first year, which is shown in 2016, we have a 46.4, and in 22 we have a 27.4. We are not still reaching the 90%, but we're working with that on that. The Cuban prevention strategy, we have an unilateral focus, but we have a biomedical and a behavioral component, everything that has to do with the legal framework. And the biomedical, we have to say that we have a condom program for more than 20 years. We have HIV tests, self-tests, syphilis and B and C hepatitis, everything financed by the World Fund. We have a national projection, but the speed tests come from the World Fund, PrEP and PEP. we used to have a PEP with uh, due to occupation, but now it's sexual also in all the municipalities of the country, in all the areas of health. At least in the capital, we have PEP, sexual PEP, and PrEP, as I said, in 15 municipalities. PEP, PrEP, or PEP. PrEP 5 years ago. And we didn't start the 5 years, in all the provinces were introduced little by little. Actually, I will tell you that uh, we have 15 municipalities with PrEP only. But, for example, I was telling the doctor that doesn't like to be called doctor, we only had in 15 municipalities. But, for example, now in this year, due to the coverage given by the World Fund, I'm the head of a program of a province. Well, in the municipalities with a high prevalence, which are five of them, besides Santa Clara, already have PrEP. The personnel is already trained that is going to offer the service, and we already have the medication and the services. We are spreading the service so that they will request for it. So we believe that by the end of the year we will have more people in PrEP. Besides the monitoring of the viral load, it's also a combined strategy of prevention. We have with the Roche platforms from the World Fund organized between the country and in three regions: West, Center, and East. And each of those has a Roche platform so that we will have a great coverage to know the status of the people. And all the world knows that when we have a suppression of a viral load, there is no transmission. And the behavioral is behavioral risk evaluation. Cuba is aligned to the WHO tool for the follow up of substantial risk. It is done, well, I have to talk to you about the.
So we're going to talk about key population. So in addition to the advice that we have as well, specifically on mental health and alcohol and other substances as well, and also what we what we just saw. So I also want to talk about the implementation of differentiated services and prevalence. So this is how we worked as well. This is how we're going to be working on, and this is how what we're going to be doing. We're going to be using just a municipality, high prevalence. We work in all 15 municipalities in La Habana, and also the municipal city hall as well. We have 30 city halls as well. We're going to focus on the good intentions. And the next one, please. I'm not going to read this because we do not have enough time, but I would like to explain about these 5 stages and what is key and fundamental as well. And we need to specialize on key population. And we were just really talking about these barriers. We were thinking about what has to do with what is related to law and these violations, and just for us to be able to get to all of the different services. So we also considered the civil society in the community as well. So this is the second stage that we have. So since service was going to be in each and every one of these provinces, so we're talking with the service vendor, with the APS, and we agree with the fact that we have COVID as well, and we need to just think about a contingency and mitigation, risk mitigation as well. And this is an answer that I have just written. This is the use of social media and the fact that at the homes of the different volunteers as well, we are just really going to hand over lubricants, condoms, just for us to be able to do all of that. So we're just really make sure that we have this type of independence as well, strengthening of services, laboratory services, orientation, guidance, prevention. We have case type 1. We needed to strengthen service. We were just strengthening all of that. So this is all for the World Fund, and we were just going to really use all of these cases specifically to the laboratory for type 1. So, stage 4 was the implementation as such. This is how we were going to do all of these services. We were just going to do all of this time schedule as well. And of course, the in the municipality as well is going to be mainly affected because people did not get there, and well, we know that they're just going to just go there, come inside from the same door. There's a lot of people who do not want to come in through the main door. They have a side door in case they do not want to do that. And also for to just provide treatment to patients. So we have all the services that we have specifically, and we have the dermatologist as well. So it is all going to be individual as well. And this is the follow-up that we're going to be giving as well. And this is a type of follow-up that we're going to be giving monitoring or the different types of services, and we're going to just give the minimum prevention. We're going to just provide advice, and this is the type of tests that we're going to be just doing, the IDS tests as well. And we also need to work with the service, and we're going to explore risks, and we need to do assessments at the very end. And we expect, and we're just going to really have this doctor visits. And we established goals, objectives as well. And this is part of the uh, different goals that we have for the minimum kit on preventions as well. We also have IT systems as well, and we had new developments to prevent duplicity in patients, both for the APS network and for the APS and a network of people that come from key populations. Sorry that I'm going on a rush because I am being very, very rushed over here. They're telling me to just rush things up, so I apologize. So it is kind of difficult to follow up on my ideas. But well, the monitoring application, we need some milestones and we have a new project. We had it for 3 years, and all of that is because we have indicators and we have allocated funds. We have also a municipality as well. We have medical doctors' offices as well, and this is a type of berries as well. We have as well, we have antiretrovirals, lubricants, condoms. We have also TB treatment as well. We have direct treatment for hepatitis C. We have platforms to follow up on viral load treatment as well. And we have this guideline and other documents that we have. We have training of key populations. I already mentioned this. And the IT system that I already mentioned. We have some challenges as well, but we need to start finishing some. So I was talking about prevention. So we're doing this type of differentiated service with everything that we need to offer. We need to accelerate the expansion of combined prevention. We need to continue as well. And I was talking to another person whether we needed some self-tests or not for a person to take that test home and to just really just hand over to their contacts and do all things. We need to direct the different research work that we have done, and all of that information is strategic, and it is key to make decisions and to also treat affected communities. We need to provide them care to continue with these prevention programs. So this is the type of things that are mainly related to what we're doing in the topic, and we're leading and guiding the communities. Thank you so much, Dr. Marleni, as well. It is a very big challenge that we have to face as well. We have some characteristics where we need to reach this first challenge, this first goal. And we would like to thank you for your participation as well. And Well, we're going to just have some questions just at the very end. These are questions as well that we are going to have with Mr. Fernando Cruz Urbina as well, and we're representing all of this, and then we're going to have Social Security as well in Peru. My apologies. We have Dr. Sergio Miguel Bejarano. So we also have representatives from the Social Security Institute from Costa Rica. We have Mr. Bejarano. And we also have an expert in geriatric gerontology. Currently, he is a coordinator in the clinical interhospital treatment of the Costa Rican Social Security Institute. He's a member of the National Board to provide comprehensive assistance to the HIV hospital in the municipality of the capital city, and he is part of the hospital that works in the prevention and care of diseases. Mr. Calderon is a professor in the postgraduate degree in the University of Costa Rica, and he's also a speaker in different pharma companies. Specifically, he addresses the topic of HIV. And we have Dr. Calderon, who is going to be sharing the answers to the HIV pandemic as well in the country of Costa Rica, the sister nation of Costa Rica. So we would like to pass the floor to Mr. Calderon.
Hola, buenos días.
Hello, good morning. A big round of applause, please, for Mr. Calderon. Thank you.
Espero que me logren escuchar bien.
I hope that you can hear me loud and clear.
No sé si ustedes tienen una presentación. Bien, muchas gracias.
Do you have the presentation? Yes, that's great.
Muy bien.
Okay. Just one more minute, please, doctor. So would you mind sharing your screen and your presentation?
¿Ya no me escuchan?
We can no longer hear you. Yes, we can hear you again.
Vamos a ver si puedo
All right, let's see if I can share my presentation with you. Can you see this screen? So you are not able to share your screen, right? I'm sorry, I am not being able to share.
¿correcto?
So, share screen, yes.
Sí, pero no me sale la
Yes,
presentación.
I'm
¿Me puede
sorry,
ayudar?
I cannot see my presentation.
Ajá, ajá, correcto.
All right, thank you.
Esta creo que no, esta computadora.
I'm sorry, we cannot do this in this computer. So, I will rejoin the meeting. Okay, so Dr. Calderon, maybe how about if you share your slides while we share
Creo
them
que no
over
se escucha,
here? I can hear you. Why don't we start while we put your.
pero vamos a ver.
Okay, just wait. So I'm sorry. I'm having looking at he's looking at his setting. When he
Ok,
starts, we will
ok.
start interpreting. Thank you. So you're going to help me with the presentation? Yes, we can
Muy
hear
bien,
you.
gracias y perdón
Okay, my apologies
por el
for
detalle.
this technical issue.
Vamos a ver si iniciamos la presentación
Let's
entonces.
see
Creo que
if we
ahí
can
vamos
begin. Okay,
empezando.
so
Yo les voy diciendo en qué momento
I
nos
will
vamos
just tell you a
a
little bit more.
Listo.
All right, thank you. So, can you see my screen and
Muy
my
bien.
slides? Okay, perfect. Thank you. Our apologies, doctor. Our apologies to our participants for the delay.
Discúlpame.
No, on the contrary.
Inconmensurablemente
We will always
complicado.
see this type
Voy a
of
hacer lo más,
issues coming up, right? So I'll
un
just
poquito
try to
posible
be
y
as
para no robarle mucho tiempo y no
explicit and
robarle
brief
puntualmente.
as possible
Bueno, la
so
manejo
that I
de
do
la
not take up a lot of
pandemia
time. So
en
this is
Costa
how we
Rica, la
handle the
primera
pandemic in
fase
of HIV
es
in
un
Costa
poco
Rica. We
más
have many sides to it, and I will try to be very fast.
orientada.
So next slide, please. Next slide, please.
Primero es hablarles un
So
poquito
we
de la
first
situación,
are going
como
to
ven.
talk about the situation.
Creo
Next
que
one.
lo más
I believe that
importante
an
es
important
enfocarnos
part is that we need to
y
focus.
dar un buen inicio
And I'm going
a
to
lo
just
mismo,
tell you
¿verdad? Porque tal vez
exactly
es
what
un
is
poquito
going on in the
complicado,
country. Maybe
un poquito menos complicado
it's a
de
little less
entenderlo.
complicated to
La
understand
idiosincrasia
this
y los diferentes
mindset
puntos de vista
and
de
some
situaciones que
aspects
consideramos
related to
importantes. Bueno,
differentiation that we
nuestro
believe to
país
be important. This is our country.
es un país pequeño,
It is a
estamos
small
sobre
country.
un poquito más de 5 millones de
It's got
habitantes
over
el día
5
de
million
hoy, lo
inhabitants
cual nos
today.
representa el
This
4%
represents
de la
about
población
4%
total.
of the total
¿Verdad?
population in Mexico.
Un país, como les digo,
And
ubicado
in
en el
the country,
centro
like
de
we said,
América, ¿verdad?
it is part of Central
Y pues
America. And well,
tiene algunas características
we have some
importantes dentro
interesting
de nuestra
characteristics as
población.
well that are part of this
Es pequeña en
population. Well, it
relación
is
al
small, of course, when
PIB.
compared against other populations.
Muy bien, el sistema
So,
de salud de Costa Rica,
the
solo para
healthcare
decirles
system in
así,
Costa Rica, just to give you an
básicamente está
idea,
formado por la
it
parte
is
pública,
basically made up
la
of the
parte
public side, the
privada,
private
muy
side.
poca parte de la
It's
población,
just
entonces casi que todo
really
está
a small
dirigido
part of the
hacia el
population.
sistema público.
Everything is
Y de
guided
ahí
and
pues
done through
en la
this
última
public
reforma del sector
service.
salud,
And in the
bajo
past
el Ministerio de Salud,
reformation
la
reform that we
Operación
had and
Nacional
of
de
the
Seguridad
healthcare
Salud
sector,
y la
we just
Capacitación en el
had
Seguro
this
Social,
Social Security Institute of
es la que
Costa
se
Rica
encarga de
is
dar
the one that is
asistencia.
responsible for the
Bajo ese
assistance as
concepto,
well.
entonces ya uno puede hacer algunas divisiones importantes. Siguiente.
Next one.
Bueno, creo que esta no se logra ver muy bien, pero
So
es al final lo que les decía, el Sistema Nacional de Salud está conformado básicamente
the
por el
healthcare
Ministerio de
system
Salud,
as well
una
is
entidad
part of
rectora,
the
la Campos Costarricense del Seguro
uh,
Social, que básicamente
And
funcionan.
also we know
Ellos
that
son los organismos, digamos,
we
que
have other
apoyan
bodies as well.
como naciones de salud y que participan en esto
We have other
para
healthcare
discutir los
systems
cambios
as well. We
futuros.
have the
Las
National
universidades
Insurance Institute
participan
as well. We
en
have
público
public
y privado,
institute, private
principios de
institutes,
estabilización
the
financiera
Costa
cambiaron,
Rican
la
Center of
sustentabilidad,
the
las
sewer system
organizaciones
as well.
comunales y los
And
servicios de salud
these are the healthcare
ayudan a
services such
promover
as
prevención
cooperative,
y demás,
self-management
que
as
se
well,
encargan de parte de la atención
that are
al
also
cliente.
just really working with the healthcare services of Costa Rica.
Ok. En Costa Rica tenemos varios niveles de complejidad en
So
el
in Costa
sector salud.
Rica, we have different
Básicamente
levels
se
of
divide en
complexity
tres
in the
niveles.
healthcare
El primer
sector.
nivel,
These are divided into three levels.
es el primer nivel,
This is
es
the first level,
el nivel asistencial menor,
and
por
this is the lower one.
decirlo de alguna manera, donde están ubicadas áreas de salud,
We have
las
some
sedes
healthcare
de los
centers as
llamados
well.
equipos básicos de atención integral de salud. Un segundo nivel,
And we have a
lógico,
second
áreas
tier
regionales y
where we
periféricas
have
y tercer nivel,
peripheral and regional hospitals.
especializados en
And we have a
hospitales
third
generales
tier
y
where we
generales
have
y los
general
hospitales
hospitals and
especializados.
specialized
Y además
hospitals as
se
well. In
incluyen las
addition to
oficinas
that, we're
básicas
including
y especializadas
other
directamente
specialized
en
centers as
algunos
well
casos puntuales.
and directly in
Esto es
some very
importante porque
specific
atrae la
aspects.
atención porque se
So
da cuenta que
this is
no hay
precisely
muchos
what we're going to
temas.
see. We're going to just really see a lot of very specific situations
Esto más o menos
going on.
solo
So
para mostrarles que
this
cada
is just
uno
to show you
tiene
how
sus
this is
funciones
divided. It is
y
divided into several
características propia
regions. We
y
have
cada
several
una de ellas tiene un marco
healthcare
gestor.
sectors, and
Esto
each and
es,
every one of them
digamos,
has a
importante
guiding
señal porque
sector.
se
This
pueden
is important
resolver
in HIV
cada uno
because
de estos
we can
lugares
do different
con diferentes
diagnostics
métodos de
and
atención,
we have
lo
different
mejor que la atención
care and
directa al
service
paciente va
methods,
a
and
ser
the
un poco
direct care
diferente.
provided to the patient is going to be done in a different way, at least a little bit different.
A manera de ver números, entonces,
So
estos
we're
son algunos
seeing
gráficos
numbers.
para
These are
mostrar
some graphs that
qué
I
pasa en
wanted
el
to
modo
show you.
diagnóstico
Once
de
again, we have the
HIV
rate of
en
new
Costa Rica.
HIV
Y
diagnosis that
ahí
we have in
nosotros
Costa
podemos
Rica. This is where numbers are
observar
shown until
más o menos
2020, but
cómo se
we
comporta
have
el
seen the
nivel de
same
atención.
behavior over the
Yo
past
creo que a
2
nivel
years.
latinoamericano
I
también
believe
la
that in
cosa
Latin
es
America,
parecida, ¿verdad?
a
Empezamos
very
a pasar
similar
por todo ese
situation has
proceso
been
de
taking place
diagnóstico,
where we have been
España,
focusing on
Chile,
diagnosis
mortalidad y
in
ya
terms
en
of
Costa Rica se avanzó
mortality,
mucho en esto.
and we see a very similar
Esta
thing going on
característica
in
de un pico más
2018.
importante de tasas de nuevo diagnóstico después cayó. Esto probablemente esté relacionado
And
justamente
this
con la
is going to
pandemia,
be
¿verdad? Y
directly linked to the pandemic. And
afortunadamente este nuevo
fortunately,
técnico que
after
trabajamos
all of
aquí
this, we
como
just really
retomamos
decided
los
to really
estudios
retake
para
some measures,
diagnosticar
some
el cáncer
actions
en
to
Costa
get the
Rica.
best
Pero la tasa
diagnosis possible in our
de
patients.
discontinuidad
But also, we
sigue
know that we have
aumentando
new diagnoses as well. We're going to talk about new
Siguiente.
data as well.
Esto representa también los nuevos casos
This also has a
actualizados de
new
diagnóstico
cases
también
of
en Costa Rica.
diagnosis as
Vean
well.
cómo viene
And
en algún momento tuvo una escalada, pero
well, we
finalmente
saw an
como que
increase at some point in time,
como que se ha estabilizado
and we have also seen some sort of stabilization, and we see some diagnosis as well.
Gráficamente lo que vamos a ver
And
es
this is
que los
virtually
números
the
en
incidence of
Costa
new
Rica
diagnosis
durante
of
2020
HIV in
están
Costa
comportamientos
Rica, and this is
que
the
después del
same behavior.
2020
In
están
2020, we have
prácticamente
seen,
el mismo comportamiento. Y vean que la tasa, por supuesto,
and this is
igual
the
que
rate
en
that
otros
we
lugares,
have.
siguen
And in
siendo
other
dobles,
places as well,
¿verdad?
this is
Los
a
hombres
men's
tienen
rate,
mucho
and
más densidad
specifically in the
que las mujeres.
HSH or MSM population more than women.
Desdichadamente, la mortalidad
So we know
ha
that
sido también
mortality has also been
un traspié realmente para los sistemas de
a
salud. Y vean cómo
situation
la tasa de
where
mortalidad
we see
es
this
muy similar
mortality rate that is very
en
similar
la
as
actualidad.
well
Y vean que desde
uh,
el
in
2015 hasta el
different
2020 vamos a ver
eras
una
as well. We
estabilización
see that
casi del
since
mismo nivel.
2015 to 2020,
Un
we see the
fenómeno muy
same
difícil, esto se está
mortality
viendo
rate.
mucho más
And
en
another
México,
phenomenon that we see in
donde
Latin
acá hay
America is that
unos,
this
digamos,
diagnosis rate
casos, los pacientes
still
llegan
continues
hasta
to
más de
increase.
la tasa de
Patients
mortalidad,
get there
más bien dicho, ya
later
a
after that as
aumentar.
well.
Y si uno ve los números a nivel mundial,
And
lo
we do
que
not see
tenemos en este
numbers as well.
comportamiento
And
definitivamente
if we do not
Latinoamérica,
see Latin
pero aquí
America
ustedes
as
vean
well,
que
and we know
son
that
bastante
Costa Rica is going to
similares.
be like that.
Siguiente. Esto es básicamente la
This
tasa
is
de incidencia,
basically the
que es muy
incidence rate, and
similar
this is the same
a lo que
behavior
vimos
that
hace
we see,
rato.
the behavior that we've seen in previous graphs. Next one.
Ok. Siguiente.
Next one.
Esta es básicamente la misma.
So basically, this is the
En
same
este
thing.
mapa lo que se
So
muestra
in
es
this
la tasa
map,
de
what
mortalidad.
we
Y
see is
uno de los puntos
mortality as
interesantes
well.
es notar que
And
si
this
ustedes
is
ven
one
los
of the
tonos
things that
purpúreos, igual los diagnósticos
I just
son
know
mayores,
that
pero
this
la tasa de mortalidad
diagnosis is
también
a little
debería
bit
ser
higher,
mucho
but this
mayor en
mortality
las
rate is
fases más
also
avanzadas.
a little bit higher in those coastal regions, what we call a Punteras y Limón and Guanacaste as well, which is part of the highest rates that we have. This rate drops centrally, probably it is also related to an early diagnosis and access to healthcare services at a faster rate when compared to other places, for instance. All right, so what is Costa Rica doing? This is also to talk about the examples that we see specifically in the country. And in the end, I'm going to show you what we're doing, how we have been doing all of this. We estimate that we're doing in over $11 as well, and we have around 1% in the HIV. This is only for HIV, and then this healthcare is also around 1.16. And in countries like ours, we have this is also represented as well, and it is a little bit higher than in other sites.
De esa composición del gas, de toda entidad
Out
financiera,
of that expense as well, by that
el
financial activity,
IMSS, como realmente sí se pagó un poco, pero bueno, la mayor cantidad
and the
fueron en
highest number
entidades
is mainly focused
públicas,
in
¿verdad?
public
Y
entities
por
as well,
supuesto
around
en la zona
95%.
azul, ¿verdad? Básicamente, de acuerdo a lo que le dije a usted al principio, las entidades que financian las
And also
administrativas,
for the activities
básicamente
as well are mainly funded in
las
the public
entidades
sector,
nacionales
these
apenas llevaban
national
el
entities as
22%
well.
y las entidades
And
internacionales apenas se llevan un 2% de todo este pastel.
so this is pretty
Y
much how the pie chart is distributed according to what I'm
todos los
mentioning.
ingresos, y ahí yo espero que lo puedan ver
So,
bien,
well,
digamos,
again, this is
el
something that we're trying to
94%
have. We have
o
90%
92%
or
prácticamente son
more,
contribuciones
around
a entidades
92%.
privadas.
These are
Nuestro
contributions
sistema
or
de
fees
salud
paid. Our
está
healthcare system
básicamente por
is
contribuciones,
basically
ahí
guided
incluye
by the
gente
different
solidaria para que
contributors who are all
tenga como
solidary
contribuir
for
contra la salud,
everyone to have
pero ahorita vamos a ver
care,
un poquito
healthcare
de cómo entra
services.
el marco
And we're
jurídico
going to
para
think
poder
about
hacerlo.
how the legal
El
framework
resto
is doing
son
in this
dependencias,
regard.
muy pocas
The
partes
rest are just
del
very
sistema
few
total realmente
parts
son
of the
costos,
total
ingresos que
funding
generan
system,
pensiones y gastos fijos.
just
Siguiente.
based on income that has nothing to do with social security.
Básicamente
So
entonces
basically,
en el pastel, y usted le
in
va a
this pie
gustar ver,
chart, as you may
el
see this in
fenómeno
blue,
de tratamiento de la composición del gasto
this is
propiamente
specifically what we have
pagado
is
por el
that
gobierno,
basically this is
en la
something that is done
jubilación
by
de los
some
del
mandatory assistance
5%
schemes. We have
prácticamente, y eso.
95%,
El pago
and all of that
voluntario
is done.
y
So
los
this
pagos externos
volunteer
es
or
apenas el
voluntary fee that is paid
30,4%
amounts to less
total
than
y el
4%,
conjunto
and
representa
as a
más del
whole, it
6%.
accounts for less than
Siguiente.
6%. Next one.
Por agente de financiación como tal, ya que la seguridad social
So now
pública
social
arranca en los
security as
92%.
well is what
Eso quiere
we're doing
decir,
with
digamos,
92%. So
que
that's
un
what we
porcentaje
mean. This is what is
relativamente
important,
más
just like with
pequeño
other countries of
es la
Latin
seguridad
America.
social y el
And that
trabajo.
means that social
Básicamente todas
security
las
basically
pensiones
has to do
y
with
el
all
resto
of
pues
the
son parte
attention as well in
del
this
presupuesto.
population. We see
Siguiente.
this as well.
Ahí sigamos, que estoy
Let's
leyendo lo
continue,
siguiente.
please.
¿Qué acciones entonces
Then what are the
seguimos?
actions?
La siguiente,
Next one, please.
la siguiente.
Next one, please.
Ahí quedó repetido, no sé por qué. Y
Next one, please.
siguiente.
Next one, please.
Avancemos dos más.
Let's move to more.
Porque quedó por de nuevo metido y se repitió. Siguiente. Entonces, en Costa Rica, para ya hablar prácticamente de lo que hemos estado haciendo, hay un marco jurídico y en
We have a legal
1993
framework, and
se
in
firmó la primera ley de VIH-Sida en
so
Costa
we
Rica.
have the
La primera
first
que fue aprobada por
HIV
gobierno
law
en
in Costa
2002,
Rica. This took place in
prácticamente para que
2022,
podamos venir a entender
and
y
this was
conocer
executed in
cómo trabajamos en
2021,
ese
and then we
sentido.
started just doing all
Este
of this
marco
in
jurídico
2022.
básicamente contiene todos los
So,
departamentos de IMSS relacionados con la
so we're
atención
still
del HIV
working
SIDA.
with the
Y
service that is
básicamente
provided
lo
in
que dice
HIV in Costa
eso
Rica.
es
So what we're saying is that the
incluso si no tiene
population,
seguro puede ser
even if they do
atendido
not have
por el
insurance,
residencial de salud
they
en
can
Costa
be
Rica.
addressed
Entonces ahí
in Costa
exactamente
Rica.
podemos
They can just
recibir
really get
el
the same
resto de las
benefits than
atenciones,
the rest
por
of the
lo menos las que
population,
corresponden a la
at
ley.
least
Pero
while
sin
we're
embargo,
just doing all
por
of this.
orden jurídica,
However, they can
básicamente,
still get this treatment
dentro de este marco jurídico
if,
para
as
que
part
lo
of this
entiendan.
legal framework, they have this
Siguiente.
possibility. Next one, please.
Hemos estado
We
trabajando
have been
también en
working
otros
as well
aspectos como la
in some other
atención, las
aspects,
normas,
such
las
as medical
sanciones.
care. We
Le
have
voy a
guidelines, we have
estar
rules that we need to enforce. I'm not going to
básicamente
talk
para
about
que
all of
usted
them
lo tenga
basically.
presente.
This
Veamos,
is just to show you
básicamente,
some
por ejemplo, la norma
examples of
para
these
pacientes.
quick and fast tests that we apply administer to the different patients all over the country. We have quick tests. All patients have free access to these tests. They can just really have access to these tests, whether they're beneficiaries or not. And these patients are later referred to any center to get care and further HIV diagnosis.
Hay el algoritmo diagnóstico que, bueno, es muy grande, no me voy a detener mucho en esto,
So I'm
pero
not going to
básicamente
just
lo que nos
really
estaba mostrando, pues
um,
hay la
get into the
accesibilidad
details of this,
bastante
but we
amplia,
have
estable,
significant
y la gente
accessibility
lo
in
puede
terms of the
hacer
test, and then the
e
patient
incluso después de
can
estar
take the
en
test, and
ciertos
even that they can be in their own department. They can be referred to their comprehensive HIV. And next one.
Entonces, básicamente,
So
esto fue
basically, just to really think
el
about
programa que seguimos.
this
Nosotros
flow
tenemos
diagram that we're
diferentes
following, we have
centros
this
acá
Ministry of
como
Health, like I
prestadores de
said, the
servicios
institute
y en los
as a
diferentes
service
niveles.
provider
En
at the
estos
different
diferentes niveles
services.
puede
At these
hacer
different
a
levels,
partir
we
de
can do
servicio
this at a second
diagnóstico
and
y
third level.
posteriormente
We're
estos
going to do the
servicios van a ir
diagnosis, and then
a
later
unas
on, we're
dependencias
going
del
to
IMSS.
take them to
En
a
este momento,
different healthcare service.
eventualmente nosotros
So at
trabajamos
a country
bastante
level,
con
we have been
distintas
working with
calidades de atención,
three
personas que reciben la
big
atención que nos facilita
care or medical
la
care
calidad de
services
servicio
where we would
de
receive and
diagnóstico
admit
inicial, que en
the
este momento
highest amount as well.
atendemos un poco más de 13.000 pacientes que están en nuestro
So
servicio
we have
académico
over
y
13,000
que
patients who are under
reciben
control,
medicamentos.
and
Ahí ustedes ven que como dependencia del tercer nivel
so
y del
and
segundo
we
nivel,
have a
también
third
tenemos
level
unas
as well.
secciones
These are these
jerárquicas que están
comprehensive
conformadas
clinics
de
as
una
well.
manera un poco heterogénea
They are a little
según la
bit
formación y
heterogeneous as
la
well,
habilidad que
based
tienen
on
y la
accessibility,
disponibilidad
the accessibility that
de
they have,
profesionales.
the
Ahí
availability of
están todos los datos de
professionals.
los
We have
servicios
medical
médicos,
care,
médicos
we
generales,
have general doctors, and we have other
latitudes,
doctors, other latitudes as well.
profesionales de
We
farmacia,
have
profesionales de psicología,
professionals in
psiquiatría, profesionales de
psychology,
enfermería, y todos conforman
and
un equipo de atención integral.
we need
Y
to
en ese
have a
equipo de
whole team
atención
of
integral lo
comprehensive
que se hace es
assistance.
toda la
And what we
atención
do is that we're going
de
to
cada
have the
uno de estos
whole
puntos
vision
para
from
tratar
all
de
of the
implementar
standpoints for us to get into this
ciertos tratamientos antirretrovirales.
drug
En este momento
delivery
nosotros
and
la
for this
respuesta
antiretroviral. So
es variable de acuerdo
this
a
is a
cada uno de
variable
los servicios,
response
porque
based on each and every one of the clinics.
ha incrementado mucho la demanda y
So
bueno,
we have
nosotros seguimos
increased demand a
trabajando con
lot.
ellos,
So
pero la
basically,
atención
this is the
también
same,
está
and
por
care
requerir.
varies in each and
Estamos
every
en el
one.
momento del diagnóstico,
And
ya
well,
estamos
when just
definiendo
really having
exactamente
this
qué
diagnosis, we're going to
requerimos
have this treatment.
las posibilidades de atención de otros profesionales en
And
toda la
we have
unidad
other
integral y
professionals as well.
básicamente
And
los primeros 7 días de
so we have
clase
these
iniciando
very
la
first
academia,
days where
en
we can
algunos
just
sitios
start
esto
with
se va a
this
ver un
treatment
poco
as well.
retrasado
And
por
then this is going to be somehow
la cuestión
lagging because sometimes
por
communication
ejemplo, el diagnóstico en primer nivel
in the
hasta
first level
pasar al de
diagnosis,
atención,
first tier
estas
diagnosis in this
dependencias de atención se
medical care
vuelven un poco más
and health, all
complicadas.
of that becomes a little
Otro
bit more
servicio que acaba de
complicated, or because
implementar.
the patient would get
Afortunadamente
a
el día
little
de
bit
hoy muchos
later as well.
contactamos con estudiantes digital único en salud,
And we
lo que
have
nosotros llamamos EDU, y a partir de allí
and
todos
well, this
quedan
is virtually
sincronizados y
how we're
podemos
going to be
poder
just
trabajar
scanning
en equipo.
everything. This is
Todos
going to
los
be
sistemas
quick
de referencia
attention. All
básicamente
the
están
reference
en la
systems
red
are
y
going
uno
to
puede
be
accesarlo rápidamente
online. We're
y
going to be able to have quick
prestar
access as well, and for that reason, care can be prompt, could be quick, expedite, and then we can start immediately in the fastest way possible.
Eh, Hay una lista oficial de medicamentos y básicamente ahí les muestro algunos ejemplos. El país se ha puesto
So we have a lot of
a, a ejercer algunos
we're just
cambios en
going
todo
to
lo que
really
es la atención
have a lot
y
of
también
changes
la
in terms of
prescripción.
care,
Tenemos
prescription
mucho de
as
hoy
well.
gracias
And
a
to
que
this
los
date, we're
médicos
going to
científicos
have
han
changes over the
mejorado
past 4 or 5 years in
domicilios
terms of care as
¿no?
well and
Y
medication and how
básicamente
everything is
hemos
just
ido cambiando el
delivered. And
medicamento
schemes
y la
have changed over
disponibilidad
time. And
tanto
basically,
para
what we're doing is that we're just
Integrasa,
really having this
básicamente como primer
list of
bucket para
Integrasa as
pacientes
part of the
que
first
han
line. We
usado
still have
medicamentos
some
nuevos
patients
por
that are
cuestión
lagging from other previous
de
lines because of an issue of logistics whenever we had to implement this.
Hay algunas otras
There are some other
estrategias que hemos
strategies that
aplicado desde la
we've
Comisión
taken
Nacional
from the Central
de Prevención
Commission
del
that I
HIV,
honor to
conformada por
chair,
7 clínicas
and
de
made up by the
referencia
8 clinics of integral
en Costa
attention
Rica,
of
7 de
HIV in
ellas
Costa Rica. Seven out of
infantil
seven of
y
these in
una
attention
en niños, ¿verdad?
for adults and one for children
Entonces,
related to the National Hospital Children.
comisión lo que
This
hace es
commission
prevenir la
establishes
diagnosis
some
en
links of
materia
importance to the
y
delivery and
prevención
strategies of treatment
con atención
with the logistic management, direction of pharmacoepidemiology, medical management, subscribe to the institution, and integral clinics of attention of HIV. So here we discuss many times the treatment and the implication it may have, and some other strategies for the Ministry of Health, like the ruling entity of health care in Costa Rica. On the other hand, we also have, like in other places, like the doctor also mentioned, the coordinating mechanism for countries, why the World Fund that gives us some resources. And here, this mechanism will suggest some changes because it's going to go to the institution directly. We are making some adjustments in this regard. In this adjustments, we receive all the help, basically focused on attention itself. And there's some composition of this where all the institutions of the government act, international cooperation institutes, as well as the civil society. So there are many NGOs in decision making. There is a National Council of AIDS that I'm going to describe later, where all these resources are taking to exercise some measurements of prevention and treatment for these patients. Well, in this mechanism, CONACIDA go together, and they exercise all the actions for the treatment of the patients. CONACIDA is subscribed to the Ministry of Health, and as I previously said, is changing, but they are the ones that execute the prevention and treatment plans and the lines of treatment for the patients. Sorry. Um, this is the chart of organizations. So there are many associations: HIV Association, Transvida, an ethnographic Costa Rican organization like Gente Positiva, Living Hope, and many other. HIV Foundation in Costa Rica, and many others that are subscribed to us. It has several objectives. I'm not going to stop here, but they have three phases basically, this project in Costa Rica. And basically, the first objective in the first stage was to stop the epidemic. I'm going to tell you some about this. In the second stage, it was basically like the in part of a better financing to have a model, which is through all this money that we can receive. And the third objective in the third stage was to consolidate the prevention model for key populations that is basically focused on HSH and transsexual people, basically, and which is included in the strategic national plan that goes from 2021 to 2026. In Costa Rica, we've been working with the PrEP therapy. There's some guidance around it, and I have to tell you that the PrEP in Costa Rica was started in Costa Rica in 2021 as a pilot program where the Ministry of Health was in charge at first to assess all the benefits and adapt it and see what the responses were culturally wise of the program as such. And now it's under analysis. Nevertheless, we are still giving PrEP privately and publicly in some public places, not in all attention clinics, and two private entities, two private and there's some guidance next. In this process of deconcentration, as I previously said, there are 8 clinics in the country, and we're looking for the way to deconcentrate the attention basically to those patients that have been stable in time, so that we will be able to download to the first level. And we are in the stage of assessing and educating
compartir todas estas
and
experiencias
sharing
con
all these
grupos de
experiences with
médicos
groups of
generales que puedan acceder a
general
través
physicians that would
de
give
nuestra
attention in
agencia o otros
HIV. In
lugares
Costa
también
Rica, as well
tenemos
as in
acceso.
other places, we have access,
Algunos ya tenemos la experiencia
and
de
some of
poder
us have
acceder a
experience to have
través
a master's degree
de
through
eh, la Universidad Rey Juan Carlos en España,
the Rey
nosotros
Juan
tenemos
Carlos University in Spain. So many of us have the master's
también
degree in HIV,
sigue
and we
existiendo
try to have more people
todos hemos
subscribed so
participado
that
como
we all
profesionales
have all
concentrados,
trained
porque la
personnel to the
necesidad existe,
concentrated
la
clinics.
cantidad
Because as I said in the
de
beginning,
oferta
the amount
es
of
menor que
offer
la
is
demanda que
less
nosotros
than the
tenemos.
demand that we have.
También hemos trabajado
We've
bastante
also
reciente
worked a lot,
y eso estamos recientemente
and this is
terminando lo que es
something recent that we've
la Guía
just
Nacional
finished.
de
It
Atención.
is in the
Esta es una
National
guía grande,
Tension
tiene alrededor de
Guides.
450
They are
páginas
big, it has
prácticamente,
more than
y en ello estamos
150
incluyendo tanto los
pages,
grupos
and we are
alto
subscribing the
riesgo
high
como
risk
algunos
group
grupos
as well as
especiales y
some
en eso
special
todos
groups.
estamos
And we've made some
en tratamiento,
amendments
sobre
in the
todo
treatment,
enfocándonos en los
basically
tratamientos
focusing
más
on
utilizados en el mundo.
the most widely
En
used
este sentir,
treatments in the world.
decirles que
For this regard, I have to say
en los últimos,
that
sobre todo
in
prácticamente antes de iniciar pandemia, Costa Rica se vio
before the
gran
beginning of the
reforma
pandemic, we
de poder
were
tener
undergoing an
diferentes
important
tratamientos
change
que se
in
puedan
order to have
manejar dentro de la
different treatments
institución,
bought
ya
through the
totalmente a través
institution
de
and
OPS
basically
para
through
tener los mejores tratamientos
OPS
para
to
los
have the
pacientes
best treatments for our
también.
patients.
Creo que por ahí me
I
tuvieron
believe that
cascada,
asked me
pero
to
no
cascade,
sé
but I am not
qué
sure
sucedió. Tal
what
vez las
happened.
diapositivas se
I think
quedó,
that
me permiten
slide
mencionar para no
got
alargarme,
lost,
porque
but I'm
como
going to
trato de
mention it
explicarla
not to take
de
that
una forma
long and not
terminal,
to try to look for it where we are
provechosa.
not going to find it.
Eh,
And
en lo que es el
well,
90-90 Costa
on the
Rica, desafortunadamente Costa Rica
1990,
no ha
unfortunately,
tenido
Costa Rica
toda
has not been able
los mejores
completely to
resultados
have the
en este
best
sentido.
results
Nosotros
in the first
en el primer objetivo como tal,
objective
trabajamos hasta
as
un
such.
85%,
We
en el segundo objetivo de
had like
pronto los
an
pacientes con
80%, and the
mejor
second
estado,
objective is to
tenemos
have
hasta
the
el
best
2%
patients.
aproximadamente
It's
de los pacientes que están en un
92% of patients
tratamiento
are under
y lo otro
treatment,
de los que están
and the
identificados
other, those that
avanzamos
are
como
not detected, we
86%.
have like
Nos hemos quedado un
86%.
poquito
So
rezagados
we
en
are a
este
little bit
sentido
behind
y
regarding this
pues estamos
matter,
tomando todas las
and
medidas
we
posibles
are
para
doing
tratar de
as much as
mejorar
possible to try to enhance
en estos números
this. criteria of quality. That is to say, if we didn't validate the data, it was not possible to go ahead. So once we had this, we started with the defined strategy and the registries that were being created in order to have this repository and then make decisions and compare and make analysis of that behavior on the execution on the way of infection. Besides the analysis of data made by at all levels, because the local part also had a part, considering that at a community level it was where more data were uh, given. So but I always say that comparisons are good, and we compare with international standards. We all have to have a direction, and the direction should be driven by excellence and the local consensus, because without it, it wouldn't have been able to have all these strategies. As for the infection mode model in our prevalence, we now can say and talk that in the key population of men that have sex with other men, the prevalence is 7.5% out of a total of this population. As for transgender people, a 29.6 is the prevalence that we have related to this population. And as for sex workers, we can validate a 4.9% in their prevalence. As for immigrants from Haiti, and I'm going to stop here, as you well know, we have a reality as a country, and that we share a border with the country that now, unhappily, is on the a state of emergency, not only in the social part, but also at all levels and all stages. So, since we have a permanent migration, and if you want, that is a very, broad migration. Somebody was asking about the response. We've also taken responsibility of all Haitian migrants that come to our country, and that come, or we try to see what their serologic condition is, and once we have detected it, then it is part of a population that is rendered the attention to. So, nevertheless, we have a great challenge, because that means a greater investment as for the warranty of rights and obligations regarding HIV. We also have as a prevalence of 4.8 of people in jail out of the people that are not free. It took up to that model took us to be able to identify which were the populations, the key populations, and the ways of transmission or infection of those diseases. Nowadays we have a reduction in compared to last year. Right now we have 24,316 cases, which means a reduction in cases. And according to what we can see with this Haitian migrants, it's a 51%, which is the greatest statistics in this population, followed by the men that have sex with other men, which is a 14%, followed by trans people and masculine adults that are competing for this, followed by feminine adults, sex workers, and children in the end, pediatric population. As for the role of institutions that I had mentioned before, it's good to clarify, because if there is something that was pretty helpful, it's the articulation between key actors. And when I talk about articulation, it's given the natural nature of our health system. We have the rendering here and the financing here, and the only way to articulate them, this triangle, is basically by sitting down at a table and decide what each one of us has to do under time frames. And based upon the function of the National Health Service, it is good to say that as a country, within our plan of health, our national health plan, we have made transparent and visualized, and it is pretty clear as an important part the reduction of mortality and lethality and the elimination of these diseases. So, since this is a very important part, we also have integrated into our national development strategy, and every institution has an important role. Is also has it also integrated in their strategic planning, and this is the way it looks. The flow as for the action in the National Service of Health, which has the health centers, public health centers, but warranties the attention to all population regardless of the regime. The prevention, where we warranty the counseling pre and post, given any kind of material, and also PrEP and PEP, the diagnosis, access to a free test, warranting something pretty important that we consider very seriously is the part of confidentiality and the privacy. The status of HIV of every user, either Dominican or foreigner, and the treatment on the follow up. We're going to talk about these strategies that is being defined, redefined, and which is the one that we want to take is the integral action that is going to be explained later on. But I only want to say now that the follow up of patients includes not only having access to the tests and coverage of them and treatments, but also any request from any lab or diagnosis or any consultation that would be required, or either going to the hospital. And the population of HIV services, which is concentrated, the AIDS that are structures that have been made up to warranty and give an answer to the population. At national level, we have 80 sites distributed among the whole population. 5 more minutes? Well, they have just told me I have to rush. I'm going to rush and explain this. This is the approach, you know, the person, can come to an attention center, by an active search within the community or by a communication mechanism that would find effective. It refers not only to the establishments of health but also any other um, place that is integrated in the answer to attention. We train them with qualified personnel, and also they are registered. We are some how intense. This is why we always say and look at the way this is performed. Now, once we have the test, if it is negative, it is also registered, and we give certain follow-up in a certain period. If there is a risk factor, it is also referred to the site, which is the system of uh, integral attention, where we give the PrEP, and through a promoter we give follow-up. It's a low risk. We have a period of 12 months for follow-up. If the person happens to have a positive test, then we give follow-up to the center in order to have a confirming test. If it is negative, we run a third test. If it is positive, then we have a follow-up where we are not only going to determine the part of a follow-up, but the index referring and the information around them and the registration, which is a condition that we must have. So the integration service plan, as I said, the application of the infection mode gave us a lot of light as for how to fight HIV. And one of the situations that we have, and which is a window for enhancement, is that the attention of HIV is pretty vertical. So migrating to the part of horizontality, what we want is this to be understood. We want a attention model, and it is pretty clear, and it says that the person, that is to say, the first level of attention as well as the second, is responsible of health for the population of a certain population. And this first level of attention, we were migrating so that the patient would be seen in a PSI, in an explicit service that is perceived as a discriminatory data. That what we wanted to warranty the attention, but the person had to go to a place to look for that attention. So everyone who goes there, uh, in any way, they are stigmatized. So We are not moving through that horizontality, and I'm just giving you an example on how in Santiago de los Caballeros, when you go there in the second province of our greatest population, and they compete against Santo Domingo, they have a first level attention center which is responsible for the attention of the population regardless of their condition. Now, in case the person has some sort of comorbidity or any health situation, is moved with the orientation of the place and the coordination strategy to a second level of attention. In case the actual same person has a disease or any condition of a greater install capability, then it is moved to a third level, but it continues to be first level attention, and that's what we want to have, that integrality in the services. Nowadays, in the PrEP, we have 3,386 people. This map includes the provinces of the Dominican Republic, and as you can see in the red dots, you can see the most vulnerable populations in the West, and it matches with the topic that Haitian migrants are more present here because they're going away from the border zones, and also because, of tourism. This is our information system. I told you that we've been very intense a little bit, but what is not measured is not changed, so we cannot miss the opportunity. We have a unique monitoring and evaluation system, and in the RESI, which is the Repository of Statistics and Research, coordinated by Conavisida as a guaranteeing entity for the answer as a country, and we have several systems of information. All are linked, they are interoperable, which makes them to have r- real-time statistics and the capability of analysis when we sit down at the table. So this is epidemiologically speaking the way it is. We have just finished a census. It tells us that we have 11 million 173 inhabitants. Out of those, 78,500 people live with HIV for a 0.71%. We have the attention cascade, our strategy 95 95 95. There we can see that in the first goal, which is basically the people that are aware of their zero-logic situation, we've reached the goal. Where we have a greater challenge is basically in the people that are receiving treatment, antiretroviral viral treatment, and the people that have this kind of treatment with a suppressed viral load, which is greater challenge there. So we continue working on a daily basis because we know it's something harsh. As for the population that have been taken with packages, we have goals in all the key populations, but we continue working with this because we're moving to some other populations. And financing, I'm going to give it to you very quickly. I'm going to tell you that state, with the very stressed interest to guarantee a response as a country, has uh, taken responsibility for the investment with an international cooperation, and within the budget we have stratified what is going to be for the test and prevention for HIV. From besides that, within the challenges, we have the part of social security because being a beneficiary, 98% of population is affiliated to these services. Nevertheless, within this social security, financing continues to be from the state, and contrary to Costa Rican example, where the contributive regime still does not give for the purpose of attention to HIV, but it is the state that is actually doing it. But thank God the projections are done with a year in advance, so we'll see what happens in the future. For the summary of the programmation in 2023, it was presented in 2022, and we will see how this financing was allocated. Part of social security, besides that within social security we do not have the coverage of antiretroviral because it's controlled by the states, but we also have all the other attentions associated to HIV, whether detection tests, consultations, and everything I mentioned previously. I'm about to finish. Don't rush me up. Here we have all the expenditure in health in terms of coverage. And something that I want to stress in this slide, something pretty important, is that we all have, obviously, within Social Security, the state insurance company, RS, as the NASA, and see in the first bar most of the amount of affiliates that they receive attention related to HIV are within SENASA for 34,517 people, which correspond to that state response to warranty all the attentions in a free way to all the people. So let's look at this, how this is diminishing and disappearing. As for the advancements regarding epidemiological surveillance, this model applied some time ago has led us to move towards the support with behavioral instrument and law, national policies, as well as all the tools that would allow us to estimate and project the prevalence of HIV and load of disease, which is the measurement continuously made to allow us to have a certainty what we have and what are the steps to follow to fight this disease. Obviously, quality control of data, the modification of indicators that have been changing with time, talking about a bulletin that generates alerts for hepatitis and HIV, and socialization of results through serologic surveillance research for key population and pregnant women. Steps to follow the implementation of the combined prevention strategy, because we have to move towards all the sanitary technologies and everything that all the international organisms like WHO prescribe as treatments that are timely and good, and provoke that key populations and people living with HIV use the prevention services, and their the stigma and discrimination topic have an important role, because besides not going to that place where they are going to give me an answer, it is actually because of what we were saying about that verticality that we've been working with. The part of the everyday analysis of the tendencies or trends of consumption and the allocation of resources of the national budget. What I told you, we also have a proposal for social security with the creation of a special fund that will give an answer and that would warranty the financing of the antiretrovirals to the beneficiaries of social security, because we're moving to 100%. Now we have a 98%. Now I want to finish with two things or 2 points. One, to thank the technical team of my country, because once again they show that integrally that's the way we have to face this situation. The HESIGs and the technical part and the National Service of Health and Conavisida, that even though they're here now, they're now completely separated. In the moment of warranting the answer as a country, they get united and do it pretty well. And with a quote that calls me to reflect of an ex former minister from Argentina, which is considered as one of the fathers of medicine in Argentina, Ramon Carrillo, says that scientific victories are useful only if they serve the people. So we talk about scientific victories. If the communities does not have real access, then it's a dead letter. It doesn't really help. Thank you very much. Thank you very much, Dr. Mora. Now, I understand that even if you don't believe it, our General Secretary wants to ask some questions. He is online. I don't know if he's going to be here, but if not, how much time would we give him? 2 minutes? Well, in the meantime, does anyone have a question for Dr. Mora? Over there. Please. Hello, good morning. Can you hear me? My name is Oscar. I'm a student in Geneva, Sweden. I represent the program of young future leaders from Cuba. I was listening to my teacher, Dr. Clara, and my question is as follows. Being aware that we eradicated mother child transmission, I would like to know in the case of the Dominican Republic what preventive measures or educations for health do you have for the education of pediatric or children population, and what are the actions that you're taking at this moment for the prevention of health of the disease. Well, pregnant women are considered as a key population, so the attention to the pregnant population and the children population, they have their own actions and flow. As for the pregnant women, the attention to pregnant women, that is also a challenge because we also have all the Haitian migrants that are most of them in maternity and nursery programs. Uh, the attention programs are there in the nurseries that or the ones that warrant the attention to the pregnant women. So within the attention protocol of a person that begins with a pregnancy, we have the test, and as soon as we know what their serologic situation is while pregnant, so the treatment is warranted. The very first thing that we have to say that we have protocols for attention. So if we follow the protocol, because I can talk about from the ideal but not the action. So if we feel, if we follow the protocol as it should be, we are going to avoid vertical transmission or infection, and then we are going to have healthy children. Thank you very much. Well, now I'm going to give the floor to our secretary. I hope we can hear him. Thank you, doctor. Thank you very much for your presentation. Thank you very much for your visit, and please send my regards to my dear friend Dr. Edward. And I want to thank you also. I would like to make or ask some questions regarding the presentation that you gave us. The day before yesterday, I was saying that the IMSS was a pioneer in the use of infection modes as a fundamental tool to go forward in detection. Probably then you would gladly acknowledge that the Council of Social Security and the Dominican Republic have advanced in this regard. But also, I want to congratulate you, and I want to know if these modes of infection continue to be the epidemiological model that you use to have the strategies for detection and attention. That is to say, these cascades of action that you were talking about during your presentations come from this epidemiological model. I would like to know about this, or if you have updated in time. I want to know if these transmission modes, the model has been developed not at a country level, but at a region or department level, a region of the Dominican Republic. And the most important question, Doctor, how did you do or how did you use the infection modes to connect with the efforts of detection of HIV? If you ever did it like that, that is to say, once we calculate the gap of people living with HIV are not aware of their status. More specifically, how did you do to use the information of infection modes to reach that group of people, or how are you doing to reach those people? Because that's a great challenge that we have in Latin American countries, and if the Dominican Republic has been able to go forward in that, it would be very useful. And finally, I want to ask you if you have a specific goal for PrEP. If PrEP is being granted to Haitian resident or visitor citizens in the Dominican Republic. If you happen to have a specific program for fighting discrimination and stigma, I would allow me to offer you the training courses that the conference, Inter-American Conference on Social Security, together with the IMSS gives, as well as ISTE. If you wish or if you consider it to be useful, we would like to help you regarding this. So those are the basic questions. It's several questions. I don't know if you will have time to answer all of them. Otherwise, I would kindly invite the doctor so that we would be able to share information, so that we would probably have a specific agreement jointly, so that we will together be able to share these modes of transmission or infection, so that we will be able to better plan the efforts of detections of the social security institutions in Mexico and the Republic and the Dominican Republic. Thank you very much. Thank you. Go ahead. Well, if I happen to forget a question, please tell me because they were like four questions, or even more. I don't know. Well, the first is that if yeah, they are used after 2009 when ONU-SIDA or ONU-AIDS took the strategy. Everything derived from there has been basically calculated through national calculations and surveillance. Uh, it was a very way how through the purpose of the model is to calculate that incidence in the population basically in the short run in order to have the reality on what the infection mode was. And once it had been identified and what was the most demanding population and the positive population, once the test was performed, so we had some surveys and epidemiological tools included in the strategy of the model of way of transmission, surveillance surveys with serologic linkage. And this is how everything that we have had has been the consequence of application ever since 2009 of this model. You were asking if you had a goal with PrEP. Yes, actually, the goal in this year went to 5,000. As I said, we have reached 3,300 and something, 80, 86. And there was another country that was, oh yeah, something that came out from our participation last year, which was pretty effective. It was to link institutions leading the response as a country as for HIV with ICSS. First, because, well, if you offered, we'll take it. And secondly, because we saw great strength. If you have some experience, and third, with the inputs and willingness to support. So, from here, on behalf of the National Concert of Social Security, after all this process, what we will do is to have a new communication to link and see in terms of discrimination effectively if we have our opportunities of enhancement because the Dominican Republic is a developing country and of course we would need this help because also we have a great population of migrants that have access to health services and by right they are also warranted to have attention regardless of their condition. And something else that you were asking if the migrant population have access to PrEP. They do. I don't know if I forgot something. I don't think so. Then, you know, if so, we'll remind you later with further communication because we do not have. We are very way behind with time. So I wish I would like to give you your certificate, Dr. Mora, signed by our General Secretary and by Dr. Gabriela Borrayo on behalf of ICSS and IMSS. Thank you very much. Now, well, let's continue. Now, we have Peru, our member from Peru. I hope we have Dr. Fernando Cruz Mendovina. We'll start by introducing him. He's an internist doctor from Federico Villarreal School with a master degree in infectious diseases. He's a main researcher in the infectology unit and in the specialty of infectology. He was the head of infectology in the institution of Social Security in Peru from 2004 and 2020. Dear Dr. Fernando Cruz Mendo, thank you very much for waiting for us, for being here, and so I will give you the floor now. Welcome.
Muchas gracias por la
Thank you very much
invitación
for the
a
invitation to
compartir
share
las experiencias de
all the
Perú.
experiences that we
Pues la
have
verdad la
had.
presentación que
Indeed, the
nosotros vamos a hacer
presentation that
un
we're going
poco
to
la
have is a
experiencia que
little bit
tenemos
the
en el Seguro
experience that we
Social
have in the Social
y
Security
vamos a
of
dar el
Peru,
marco
and we're
correspondiente.
going to give a
No
framework
sé
to
si
this.
podemos
I don't know if we
empezar
can actually
rápidamente
begin very
porque lo
quickly
único que
because
nos
the only
separa,
thing
digamos,
that
el
separates
almuerzo y el estudio
lunch and
es
us
que
is my
vamos a
talk.
tratar de
So let's try
presentar
to
esto
be or
en un
give
tiempo no
the
tan
proper
asignados.
time
Bueno,
and
y le inicio un poquito, lo vamos a
say
hacer de una
whatever I
forma
have to
muy
say.
rápida.
This is
No sé
the
si se escucha bien, por favor.
agenda that we're going to have. I don't know if you can hear me well. Yeah, we can hear you pretty well. Don't
Perfecto,
worry.
esta es la hoja de ruta
Well,
que
this
nosotros vamos
is
a seguir.
the agenda that we're going to
Primero vamos a
follow
hablar un
today.
poquito
We're
de la
going to talk
Organización del
about
Seguro Social
the
en Perú.
Organization of
Hoy día
Social
se
Security in
llama
Peru,
Salud.
which is called
El
ESALUD,
proceso de registro y
the
reporte
process
de
of registry
información
and
y reporte
report of
epidemiológico
information and
y las
epidemiological
experiencias en su
report, and the
hospital que se
experiences in our
encuentran
hospital,
ubicadas por
which
aquí
is the
arriba. Es
National
el hospital más
Hospital
grande de la
Edgardo
región
Rabatian
Social de Perú
Martins, which is the
y
greatest
cuenta
hospital
con
in
2.000
Peru,
camas
and
y
that
una
has
serie de distintas
2,000
especialidades.
beds
Entonces
and
vamos a hacer
several super
prácticamente
specialties.
representativo de
So
lo
that's
que
going to be
nosotros
very
desarrollamos
representative of
en
what
la
we
atención
do in the
médica a la
attention to
pandemia que hoy
this
día nos
epidemic
apoderó y
that
fue
now
sin
is
lugar a
gathering
dudas
us
uno de los
together,
temas más
and
trascendentes
which
por
is
lo menos
one
en
of
los
the
últimos
most
30
important
años. La
responses
siguiente,
that
por
we have
favor.
had in the last 30 years.
Miren, esta es la Organización del
So
Seguro
this is the
Social
organization of Social
de
Security.
salud. Digamos,
The
actualmente tenemos
national population of Peru
33
is
millones 726 habitantes. La población asegurada por lo menos
33,727,000
corresponde a 2
million
millones
inhabitants.
de
And now
personas.
the
Nosotros
beneficiaries is
tenemos
12
atención a
millions.
nivel de
We have
todo el
attention
país. El Seguro
at
Social atiende a
nationwide.
todos los especialistas a nivel del Perú
The
y tenemos alrededor de
we have
400
around
centros
400
que dan salud
centers that
en todas partes del
give
Perú.
services of
Tenemos
health all
diferentes
over
niveles,
Peru.
como
We
decía
have
usted ahí,
different
tenemos el
levels,
nivel uno nivel 2 nivel 3
first, second, and
y
third level,
tenemos
and we
básicamente
have
una gran cobertura en
basically
el
a
nivel
great
2 donde
coverage
tenemos
at
ya más de
first
30
level
centros
where
y
we have
aquí en
almost
el nivel 2
300 centers,
y el 3
and in
digamos
level 2
hospitales
and
de mayor
level 3
complejidad.
the
El
more
libro rojo es
complex
un
the
teaser de lo que nosotros
hospitals.
hacemos,
I cannot
es
see
una
the
definición.
uh,
Este,
slide pretty
bueno,
well,
la
but
siguiente por
anyways,
favor.
second, next please.
Digamos, esto
So
digamos, es un poquito para mostrar los
this
elementos
is to show you
normativos
the
que tenemos
regulating
y que son
elements
necesarios
that we
digamos,
have, which is
capacitar con
the
lo que
fundamental
respecta a
part
los conocimientos
regarding
y a las bases,
knowledge
sobre
and the
todo normativas que
basis
tiene todo esto.
of
Actualmente
regulations
nosotros
that
desde
we
el
have.
punto de vista
From
normativo tenemos el
our
Ministerio
regulation
de
point
Salud
of view,
de nuestro
we
país.
report to the Ministry
Sin
of Health
embargo,
of our country. Nevertheless, Social Security
el Seguro Social
has
es un ente prácticamente
is an
depende,
independent entity,
autofinanciado por los aportes de todos los
self-financed by the
trabajadores de la seguridad
contributions of all
social.
workers of
Entonces,
Social
hay una serie de
Security.
normativas en
So there is
materia
a
de
set of
auxilio, tenemos normativa
regulations from
para el VIH
2010.
que
We
se hace
have regulations for HIV
anualmente y que nos van a
performed
mostrar todo
yearly or
todo lo
bi-yearly
que
that will
hacemos
show
como
us all
herramienta
we
para
do as
manejar
a
este tipo de
regulation
pacientes
to
y el
manage
manejo
all these
de esta
patients
endemia, de esta
and
enfermedad.
this
La siguiente, por favor.
endemic.
La atención, como
The
ustedes ya lo
attention,
han venido
as you've
diciendo y todos lo
been
conocemos, estamos
saying, and we
integrados
all are
en el manejo de
aware,
este tipo de pacientes, ¿no?
those that
La
work with
atención es
these
una
patients, the
atención de tipo
attention is that
integral,
an integral kind of
multidisciplinaria, y obviamente hoy día la
multidisciplinary.
virtualidad
And the
y digamos
virtuality now
el proceso el advenimiento del internet
and
y todas
the
estas redes
coming of
sociales
internet and all
comunicaciones
social
nos han
media that we
permitido a
can
nosotros, por ejemplo,
have
establecer
allowed
una
us to
serie
establish
una
a
red de
series or
infectólogos
an
de salud que son
infectologist
los que dan
network
terapia antirretroviral,
that give
una red de
antiretroviral
coordinadores
viral therapy, a
red de
network of
bioinformación psicológica
coordinators network of nurses that give attention to these therapies, and a reduced group of coordinators at the centers giving therapy in the city of Lima. And on the other side, I have to tell you that the epidemic in our country, like any other countries in the world, is a focused epidemic. 58% of HIV patients are in Lima, and that happened from the beginning of the epidemic, and it continues like this. So, nevertheless, um, the experience that we've been having is the experience of Social Security of Peru. So we have an internal coordination in our country, and we are permanently coordinating with MINSA, which is the Ministry of Health in our country, and ourselves. We have hospitals and other entities of health that render attention to our HIV patients, like the armed forces and the police forces. And when we say others, there is a group of organizations that are NGOs that also help with prevention and the management of these patients, and sometimes they've been integrated to the group of entities that render treatment as part of the treatment granted by the states. The workers responsible of these management and all these institutions are going to be ruling entities like the Ministry of Health, and we as Social Security, we manage 25% of these patients, which is e-salud, and then the armed forces and police forces. Police forces. We are working interinstitutionally and in an organized way, and there's always some features in the social security due to the kind of attention that we give, so that the patients of social security will be the ones that contribute for the attention, and it's an entity that does not receive any money from the state. Okay, now the integral attention has allowed us to have these patients are patients that have a defined job and that contribute to social security, but there are circumstances where they lose their insurance and they lose the condition of beneficiary, and there's an interinstitutional coordination where the patient not having these right or this service, we have an integrated network so that they will continue with their treatment. We can have a geo-reference to locate these patients and to render them all the attention they need. This is managed bidirectionally. So the patients with MINSA and have an insurance come with us, and on the other way around, those that do not have an insurance, they will go with MINSA, but they will not miss any treatment or prevention methods or everything that has been established by law against HIV. Next, please. This is the registry and report information process. So as you can see, well, in here we have the regulations and the regulations that support this kind of attention, multidisciplinary attention. We all know that the HIV patient attention should be multidisciplinary. We can see here that we have attention on the part of the doctors, nutrologists, nurses, social workers, and psychologists that are going to help the people in scheduled dates. They have programmed consultations for these kind of patients at all levels of attentions, from first and third level, which together we have more than 400 centers that give treatment all over the country in all the provinces in our country. So the management, as you can see, is multidisciplinary, and obviously these slides that we have just seen shows us how we have the scheduling for the attention in the medical area, nursing, nutrition, and psychology areas, as well as the social service area, which is paramount to us because the insurance integrates the beneficiary and their family members. So now that we can see, here is the smart health service established in March 2019, which was basically the digitalization of medical records. That's an electronic medical record. It started in 2019 when we had a great step back from the pandemic on, but nowadays this smart health service is installed in all the 400 centers, and it's an electronic report that the patient can be in the border or within the country, and through this smart system we can see what his attention and his everything that he would have been going through. We can see tests and some reports of what he has been going through. This had a lot of difficulties, and despite this, we've been able to do this electronically. So we have information of the 400 centers, and that's a very important thing that we did, where we can actually see if an HIV patient was attended at the internal or general medicine department, or serologist, or surgery, or if they had an accident or whatever. So this smart health service with this electronic report is helping us a lot, and it's under perfectioning process. And we can see how we have been able to help these HIV patients through this. Next slide, please. In order to establish this kind of electronic record, we have had a code catalog for all medical procedures, and this digital medical report generates statistical reports, real-time information is related, all the requirements of the user. So we relate all the advancements of the patient in the different attention centers. It's working pretty well, but we are still needing to perfect it, and we need to have a more adequate management. We have some problem with internet signal some in some places in the country. Next. This is to show you, this is just a screenshot to see there is a series of tools that articulate the social security and detention of the HIV patients with the Ministry of Health. We have quarterly reports made by to the Ministry of Health, but on the other hand we also have a monitoring and report of treatments for hepatitis B that are also performed continuously, and they are focused to the Ministry of Health to give us global figures. There is a series of you know legal background or regulation background there, where there is a series of ministerial resolutions where we have the numbers. We have to have a screening of HIV, and one of the goals that the program has said is that all patients to medical consultations we should screen at least 10% for HIV. This has been surpassed, and we do a lot of screening. This, for example, is the screening that we have for HIV nationwide in health from 1918 to 2023. And there we see there that we screen on a monthly basis around 7,000. I cannot see the slide properly. We can enhance that. Um, we have a permanent screening that you can see there. Obviously, there's a date which is key to us, which is the pandemic. From 2020, our screening went down, and now we are recovering this level of screening for patients. We screen on a monthly basis like 40,000 patients. The same, the screening of women, lactating, and the screening of the women lactating is 100%. I think it is not only in our country. lactating are screened for HIV except for the uh, woman that does not go to a health service, but we try in the places to look for those patients. So this happens in the first consultation of a lactating woman. We do this screening. We have a vast test, and we screen the patient, and we define it as positive or negative in order to give them attention. The lactating women have a prioritized attention. So once they go to the consultation, that day she is screened for HIV. If she happens to be positive, she then becomes a priority and she's integrated to the confirmation of diagnosis. And after confirmation, she receives treatment vertically, very quickly. Screening of lactating women. I don't know if you can see them clearly. Can you see these? Um, well, we can see them clearly. Maybe it is your screen, but we can see it clearly. I cannot hear you. Ah, we can hear it clearly. Unfortunately, I cannot hear you. Now I ask to share my slides, but I'm seeing what I have uploaded. Can you see them? Yeah, yeah, we can see them. I don't know if you can help me in the technical part so that he can hear me. Thank you very much. We can see them, doctor. I don't know if you can allow me to share my screen and then maybe I will show my slides. I don't know if it is okay.
Right, because I cannot see anything from the slides, unfortunately. Well, we can see this here. So, can you please allow me to share my screen? Yes, if possible. Let me see if that's possible. Yes, it is possible. Okay, so please try to do so. Let's see if you can do that. Okay, so my apologies. I don't know if you're able to just really, I don't know if you can see that. Yes, we can see you specifically. Okay, so we have HIG screening. So can you see my screen? Yes, we can see your screen. All right, all right. So we were just really trying to show you what would we have screened as patients with HIV. How many patients we screen on a monthly basis for HIV? Around 40,000. And this dropped during the pandemic as everywhere else in the world. But then we start to just recover slowly. We have now 40,000 monthly screenings that we do at the Social Security Institute for HIV. And now, of course, like I was telling you, in pregnant women, that's something that is not only happening in our institution, but everywhere in the country. So now take a look at this. These are the screenings that we do. We have around 7,000 pregnant women per month across the institution, and over here we have in 2019. So again, this is a pre-pandemic, and then we also saw a drop in this number in the pandemic number of screenings, and now we have also gone back to 7,000 per month. We have 7,000 pregnant women per month. So now concerning TB patients and their HIV screening, well, we know that in our institution we cannot really talk about the fact that we have some regulatory provisions with these legal frameworks provide for specifically that everything in TB needs to be screened for HIV. We do have managed to really attain this goal because everything is related to the checking of patients for just to rule out HIV. So take a look at this. Patients with TB since 2019 and to date we have around 600 patients with TB who have been registered for HIV screening. Same thing during the pandemic. We dropped this review, and now with this medical checkup, we have also patients with TB and HIV. Now, concerning the offer of antiretroviral, this is something that we do. We only have this uh, percentage of the population in Peru, we have been growing in terms of the number of centers that we have really seen in terms of therapy all over the country. And this is the map that we have in the country. So everything that you see here in dark blue, these are the centers that we
Hoy
have in
en día ya
2011.
logramos también una cobertura en todo
We
nuestro
have
país.
coverage all over
Tenemos
the
24
country.
centros de
We
atención
have
primaria
24 centers
de
nationwide
Sociopolitical.
that provide
Una de las fortalezas que
antiretroviral
tenemos
therapy.
como Seguro Social es que en todos los
So, as
centros donde
social
damos terapia atención
service as
primaria
well,
tenemos
and
gente especializada, tenemos en la mayoría de ellos
so in
infectólogos,
most cases
muchos
are
internistas
all
entrenados para
infectologists.
la
They
terapia
have been
antirretroviral.
trained.
Es una de las fortalezas que tiene el programa de VIH en la seguridad
So we
social.
have HIV for
Digamos,
social
como un
security,
buen programa
and
del
given the
Ministerio de Salud,
magnitude of
vamos,
the healthcare
que hace
service
una,
as well,
unos tratamientos, pero
and
lo cual es
this is the
muy
type of
bueno.
treatment that
Sin
we
embargo,
provide as
es una de
well.
nuestras
And
fortalezas que cada uno de
however,
estos centros
we
donde
know
damos
that all of
terapia
our
antirretroviral tenemos
centers,
gente muy especializada.
and we have very specialized people.
Las intervenciones estratégicas para el control de las
And we believe
ITS,
that to control
obviamente, todos
STS,
ustedes ya tenemos
SDTs, I'm
orden
sorry,
familia,
we know that we wanted to have,
controlamos preservativos, tenemos normas y reglamentos
we
y
have
una serie
rules,
de protocolos
regulation,
para el manejo sindrómico de las infecciones de transmisión
we have
sexual,
a
la
diseases
profilaxis
as well.
preexposición. Es que
We
saben
have,
que quiero solamente dos cosas. La
I only
profilaxis
want two
en
things,
nuestro país recién se está implementando en el Ministerio de Salud. Nosotros no damos PrEP. En este
and
momento,
we
la
are
Seguridad
not just
Social
really
de
doing social
Perú no
security,
entrega PrEP.
and
Estamos
we do
en
not have
plena
prep. We
elaboración de
have
lo que será el PrEP
just
en
they
nuestra
have been
institución.
developing the
Tenemos que ver
institution
cómo
and
lo
all of that, and we
abordamos,
need
cómo
to
lo
see how
reglamentamos,
things are
porque
done, how
nosotros,
things are
digamos, tenemos
regulated,
algunas dificultades desde el
and
punto de vista de funcionamiento, porque nosotros solamente atendemos a los
we are
pacientes
also
que
working.
tienen
We're only working
incapacitarse,
with
que
patients who
aportan a
have
la
a
seguridad social.
steady
Entonces,
job. They are
eso
contributing to
tiene
social
que
security,
modificarse.
and we
El
just need to change
Ministerio
all of these
ya en
things. But
nuestro
the
país, como
ministry in
todas
our
las EPS,
country
ya tiene un
already
programa
began to
ya
have prep,
establecido y nosotros
and
todavía estamos digamos, en la
we
elaboración de
have
un
not
plan para
really have
establecer el
a
PrEP en el
plan
Seguro
to
Social. De
start
momento
this
no
prep with the
tenemos
social
PrEP en
security
el
as
Seguro
well.
Social. Quisiera
5 more
contarles
minutes.
ahora la información epidemiológica
We
que
have more
tenemos
epidemiological
y que
information that
permite
we
a la
have
institución, por
from
ejemplo, nosotros en las
2023,
barras rojas
and
tenemos
also
el
this is
índice de
the red bar that we
contaminación
have
y
in
en las barras
the
celestes
cases
o
of.
azules
We have
las
these
tasas de
blue
infección por VIH.
bars as well. We have the cases of
Obviamente, digamos que
infection,
tenemos
and
alrededor, miren, de veintitantos mil o 23.000, 24.000
we
pacientes
have
notificados. Pero los
23,000
números
patients as
estadísticos que
well.
hay
This is
en
the
el Perú,
population of patients with
según el
HIV,
reporte del Ministerio de
and this
Salud,
is the
son
ministry
120.000
as well.
pacientes que viven con
And we
VIH en
have
Perú.
patients who live
Nosotros
with
tenemos,
HIV in
como ven
Peru as
ustedes,
well. And as
alrededor de
you
24.000
may
pacientes
see
de
that we have
100.000 pacientes que
24,000
maneja la
patients as
Seguridad
well,
Social.
and this is
Tenemos
what we have been doing.
vicepresidenta
We have been
del
working with the
Ministerio de Salud.
Ministry of
Nosotros
Health
no
as well,
manejamos el
and we
25%.
have been working at least with
Vean ustedes
20%.
esto de aquí
So this is
se
what we
refiere
do.
a la tasa de incidencia
So this is
acumulada
the
del
rate of
VIH en la
incidence.
región
So
hasta
in
el año
year
2013
2000
y van a ver
towards year
ustedes un rojo bastante
2023,
sigla
and
y
so still going to be doing that, and we're going to see
la
infection
tasa
with
de
HIV,
prevalencia del VIH es
and the prevalence
12,7
rate
sigla
is
y
a
la tasa de prevalencia
10 in
del
12
SIDA es de 5,8
beneficiaries,
sigla.
and then it's 5 in
Esta raya son
10,000
unos comicios bastante
beneficiaries, and then
muy
we are
parecidos
also
con
working
algunas
in
que tiene el
this with this
Ministerio de
curve
Salud, que
with the
hablan hasta del
Ministry of
10% del
Health, and
producto,
this
porque
encompasses
digamos,
20%
el
of the whole
Ministerio
thing, because the
tiene
ministry
información
includes our
satisfactoria sobre lo que está
information as well,
implementando
because
la
we're all
Seguridad Social.
centralizing all of this.
Esta es una cosa
And this
interesante,
is something
digamos,
that is very
de repente
interesting.
estas instituciones
Sometimes we realize that our institution
pacientes
has
notificados con
some
VIH,
very
SIDA que
special
tienen modo de
situations. We
transmisión.
have
Miren ustedes,
HIV
la
patients
transmisión
that are
sexual es
still
más del 90%,
transmitting
casi el
their
80% en todo el mundo.
or
Nosotros,
communicating their
digamos, tratamos en nuestra
disease, and
evaluación
we
del paciente
have
y en la
to
evaluación de la historia
ask
clínica
questions
de
through
determinar si esta
questionnaires.
transmisión
We
es
have to
sexual.
do
Por ejemplo,
assessments. We
para
need
las
to
homosexuales,
determine, let's say for
es del
heterosexuals,
49.6%.
49.7% of
Homosexuales,
patients, homosexuals
exclusivamente
exclusively
32%.
32%,
Bisexuales,
bisexuals
11.9%.
11.9%,
Unas datas de
and
infección
we
todavía
know
no
that
terminadas,
sexual
escasas,
transmission has
alrededor
not
de
finished, and we have all of
transmisión
these non
sexual es del
determined or
1%.
determined cases. We are
Todavía
talking
estamos
about
infiltrados en
21%,
contaminantes
and
transmisibles
whether
del
if it is through
1,1%.
contaminants, less
Entonces,
than
esto, digamos, es una
0.21%. So
configuración
this is a
bastante
type of
frecuente en todo el mundo.
frequent
Sin embargo, la
situation that we
mayoría de
have
las
seen all over the world. And
intervenciones
also,
tratamos
what is
de
special about that our institution is that
disminuir
we
la
have
transmisión
tried to
sexual,
talk
no se
about
sabe la
whether it
transmisión,
is
pero cuando uno
bisexual,
estudia la transmisión
homosexual,
sexual se encuentra
or heterosexual, and then when we see that when it is heterosexual is above 90% of this transmission. So we have also pinpointed HIV patients through the different networks. So the very first top networks that we have the Rivalta Hospital, Alberto Sabogar Hospital, and Guillermo Almenara Hospital as well. These three main networks are the largest networks that we have in Social Security in Peru, in Lima, these three ones as
Y
well.
obviamente, si ustedes miran la cantidad de los pacientes que
And if
tienen
you take a
VIH,
look at the
anda
patients
por
of
encima del
HIV,
50%.
they're just going
Y
above
eso no condice a
75%. This also
detectar
confirms something that we
presencia de
already know
forma
and we have known for a long time,
desproporcionada de una
and
epidemia
that is that
concentrada.
we are
La
a
cantidad de
concentrated
muertos que
epidemic
tenemos en
as well,
Perú y
and
Lima
Peru and
oscila alrededor del
everything, and that
60% y
concentrates
el
just everything as
58%
well.
de los
58% of
VIH
patients living
están en
with
la
HIV,
ciudad de Lima.
and
Y
they're
esto,
all living in
a
the
nosotros
city
se
of
nos
Lima.
confirma
So
cuando
we have
miramos
been
nuestras
confirming
RT
all of
y
this as
bajamos
well.
de
And
las
then
ciudades
as well, we have
alrededor de Almenara, que no
Almenara,
puede
Salgogal, and
decirse
these
de las
are
estructuras locales
also
en la ciudad
some
de Lima, ¿no?
distribution
A
of
continuación
networks all
está
over
la
the
región
city of
norte,
Lima.
luego
Right
nos
now,
vamos al norte del
we
país
have a
y luego vamos
department
al
in the
norte.
northern
Y todas
part
son
of the
cifras
country. These are
que
some
estamos
numbers that
para
we still
completar
have
el
to
país
continue
como una
just really
entidad.
finishing
Sin
with the
embargo, les
country
puedo
as a
decir
whole.
esto,
However, what I
lo que
could tell
tenemos
you is that
concentrado
we are a
es que mirando
concentrated
nuestro recorrido
epidemic. We have
epidemiológico,
HIV.
los casos de
Whenever we
SIDA
see the case of
también tienen
AIDS,
prevalencia en
and we
Almenara,
see
Saludar. Lo
Almenara,
tenemos
Saludar, and all of
en
these places, but
La
we have La
Mayeque.
Mayeque. La
Y La Mayeque
Mayeque
es un
is
departamento al norte de
a
nuestro
district
país,
that we
en la
have the
costa
northern
norte de
part
nuestro
of
país,
the
y
coastal northern part of our
lamentablemente
country,
presenta muchos
and
pacientes
we
con
have
VIH
reported a lot of
avanzado
cases of
y además
patients with
invisible.
advanced
Y todas
HIV,
son
AIDS
poblaciones
as well,
importantes.
and
Inclusive
this becomes
puedo
relevant.
colocar
And
como
let's see, this
reporte
is the
los
third
casos de
rank.
SIDA, o sea, como
These are the
enfermedad
cases of
basal.
AIDS as an advanced
Y cuando uno
disease.
mira la pirámide
So whenever we see the
etaria,
pyramid
uno
by
encuentra que
age,
obviamente es lo que pasa en gran parte del mundo, ¿no? Entre los 20 y 25 años
so
hasta los 45 o 50 años es la mayor
So we're
cantidad
just really
de
trying to do
pacientes
that.
reportados
So
con
these are the
VIH,
patients that we have
digamos,
reported with
masculinos
HIV.
del sexo masculino, como van a ver ustedes.
So
Tenemos
these
una
are
proporción de 4 a
male
1
patients.
nosotros
We have
en
a
orden
4 to 1
de
ratio,
presencia.
women and
Cada
men.
vez peor.
And so we have men here. We lost audio for a minute.
Pacientes con
So we
VIH,
have
la más
patients with
popular.
HIV. So with the
Ahora,
AIDS
cuando
space,
uno
it's pretty
mira
much the
las
same. So whenever we're
enfermedades
taking a look at
comorbilidades de una población,
comorbidity in
obviamente pues
TB as well,
nuevamente la epidemia
and
concentral, la que ya
we
como
know
hablamos
that,
de
well,
desarrollo
we
social,
have
son
Almenar
los que
and
tienen
Freedom
más
and
pacientes
everything. These are
VIH
the cases
con
that have most
tuberculosis. Como
HIV
van
with
a ver
TB.
ustedes aquí,
And as you're going
nosotros
to see as
concentramos
well,
en Lima
we are
los
really
casos de
focusing
VIH
in
con
Lima
mayor
the highest
incidencia en
number of
tuberculosis.
patients with co-infection.
Cuando uno mira
And whenever
las
we
tasas de incidencia
take a look at the
secundariamente es un
incidence rate as
departamento de
well
solo
in a given
psiquiatría
district,
y la tasa
from where
secundaria
they
tiene
come from, and
incidencia
also with this
relacionada
see
a la
this
población
incidence
y
rate, we
cada
see
uno
the
de los departamentos.
population
Van a ver
that is
ustedes que el
found in
departamento del oriente,
all of that. We
o sea, aquellos que
see
tienen
the
frontera con
district
Brasil o
that is to
Colombia,
the
¿no?
west, meaning they
Esos
are
departamentos son los que tienen
near
la
to the
tasa
border
de
of Peru
incidencia
or
mucho
Colombia or
más
Brazil.
elevada.
They have the
El
highest
cuarto
rates
rango,
as well. But
incidencia
we're
total
talking
de
about
VIH.
also
Sin
accumulated
embargo, cuando uno mira
incidents as
las
well.
tasas acumuladas
And
en los
whenever we
pacientes
take a
con
look
SIDA,
at
uno encuentra
patients with
que los
AIDS,
pacientes más
we
avanzados
know
en
that the
Europa,
most advanced
en la
patients
costa
as well
pacífico,
in
es
the
la que tiene la mayor
Pacific
incidencia.
coast,
Obviamente las
that's where
ciudades
we
más
see the
exitosas, el
highest
60%
rate
vive
as well.
obviamente
This is
ahí,
where we
son las
see
ciudades de Anca, la
everything in
Libertad,
Anca
quizás la
Libertad as
Mayeque,
well.
que es
And
uno de los centros
we
donde
have
más
one of the
pacientes con
centers as
con
well.
enfermedad
Patients with
avanzada
HIV,
tienen hospitales.
they have more advanced diagnosis as well,
Eh,
and they have diagnosed this.
y estas son las gestantes notificadas o
So
aseguradas con VIH por eso.
HIV
Obviamente, nuevamente en
and
Lima
all of that
concentramos
through
la tasa de
network in
contagios
Lima, Peru as
y
well, and all of
ustedes en
that
los
we have
últimos años
different
hemos
places,
tenido un
and
total de
we have
hospitalizados
had a
por
total since
COVID-19 al 2023
2019,
256
and we have
gestantes con VIH, ¿no?
256.
Que podemos ampliar
And
la
well, we're
tabla si
still
gusta
going to see
verticales.
what is the
Es muy
vertical
interesante porque ha
aspects as
disminuido
well,
la
and
cantidad de
this is how
gestantes
we
en
have
todo
been
el país.
dropping everything significantly.
Estos son niños que
And
tienen
these
entre 0
are
y 11 años que
just
tienen VIH.
children from 0 and 20 years old.
Si miramos estos últimos 5
So if we
años,
take a look
tenemos
at these
23
last
niños, 23
25 years,
niños
we have
de 0 y 11 años, de
23 years
2019 a
as well.
2023. Y la
And well, in
concentración más alta está
2023, and the
en el
largest
hospital de VIH de
concentration
Lima,
is in the
La
Hospital de
Mayeque,
Belvete in
este
Lima.
departamento
That is the
donde hay
highest
muchos pacientes
company.
con
We have a lot of
avanzada,
patients with an
alto,
advanced
y ellos
age.
obviamente
And of
ya
course,
están
we
tomadas
have
las previsiones
realized
con lo que
that they
correspondiente
have
para poderlas
already taken
trabajar
their
en este
treatment and
aspecto,
they
¿no?
have just been working
Eh,
and all of this.
Ahora estos son los casos de niños con SIDA que hemos hecho 20
We
Bueno,
have children with AIDS as well.
en todas nuestras redes y obviamente
And
algunas
what
redes
else?
global que son un
We
poco
also have
desconocidas, pero
Mesawal,
que
where
son
we
más
have a
importantes.
concentration of the youngest ones as well.
Cuando uno mira las
And
defunciones, ¿no? Entonces miren las defunciones, está la tasa de mortalidad está acá
we
abajo.
have
Aquí la
the
tenemos, por favor,
mortality
no lo
rate,
tomen en cuenta,
and
¿no?
so
Vamos a la tasa de letalidad para
we
el
have the
2019,
lethality or
para que ustedes
mortality rate
puedan
as
tenerlo,
well.
la tasa total de defunciones por día
We
2004
have
a
this rate as
2022
well,
y la tasa de
and
letalidad para el
we have the
2019
lethality
es
rate as well, and
19%.
it's
Hemos tomado
19% as well.
2019 porque
So
después
we have
sacamos
been
algunos
working in
reportes,
2019,
básicamente eran muertes por COVID,
and we are going to have death
no se reportaba
caused
esto por
by
ese tipo de
COVID.
datos.
We have not seen
Esta es, digamos,
HIV
para gráficas
patients
como
as
ejemplo
well,
de la gente que
and
nosotros ya
we
tenemos
have
en
been
nuestro
just
país.
doing
Este es un
this
informe del Instituto de Salud de
antiretroviral
nuestro país,
therapy as well. This
donde
is
nos
what we
habla de
do in
cómo ha ido
terms of health,
creciendo la tasa
and
de
this is
enfermedad
how we
en
have been
nuestro
doing
país.
all of that.
Y hoy en día,
And
en diciembre del
today,
año
out
pasado,
of the
siempre dijimos que había
110,000
tenido
patients living with HIV and
81%,
Peru,
porque obviamente
81%
el,
obviously have been
reciben
just really
terapias de
receiving
retroviral. Son
antiretroviral
muchos años, ¿no?
therapy. We're talking about
Estamos todavía
90,000
lejos de la
patients.
meta
We're still
absoluta para el
far from our
2025,
goal
que es
by
el
2025,
95.
which is
No es
95%, right?
algo que hemos
However,
avanzado
we have
a través
moved
de los
forward,
años
we
con
have
la técnica
progressed,
oncomal y las
and
estrategias para ir
also the
avanzando en esto,
strategies as
para
well,
que
and
se
everything that we
recupere la
have been
equidad,
progressing. We have
básicamente a esquemas
migration of
dosis
therapy,
fijas
migration to
asignadas con
other
COVID, la
fixed dosage as
dosimetría
well,
y la
and
dosificación
we also
asistida
have the
remontable
assisted
y el trabajo que está haciendo
notification as
cada
well, and the work
región
that
del
we have been
trabajo, ¿no?
doing
Con
just
estos
for us
datos
to
les
be able to
sugiere,
recover whatever has been
miren,
dropped or
los
abandoned as
indicadores
treatment. So
para el
these are
2020
the
y
indicators that
2090,
we have
¿no?
by
Ustedes ven que
2020
la meta era 90,
and
90, 90,
1990 as
para
well.
nosotros en ese momento en
That's
Perú, que
where
siempre
in
fue
Peru, at least, that was the
beneficiario, ¿no?
source of the Ministry of Health,
Conociendo ya en
and
cifras
that's what we found
cerca
as
del
well. And
90%, estaban en tratamiento 87%, también muy
this is
cerca
something
del
that
90%,
we have
pero
been
cuando
doing
hablamos
in
de la
1990,
respuesta,
and
también de esta estabilidad de nuestros
we are
pacientes,
just working with our
miren,
patients,
42%
and
estaban, 42% de los pacientes
48%
estaban
of the
suprimidos.
patients have
Sin
been
embargo,
suppressed.
hay una falla de un
And
nueve por
however,
ciento que tiene
there
que
is
sumar
a
al mismo
failure.
dos,
We
pero un
have a
40%
lot
de
of
los
copies,
pacientes
but we have
suprimidos de carga
40%
viral.
who do
Y
not
este
have
fue
any
uno de
sort
los
of
problemas más
viral
serios
load
que tuvo
tests, and
IMSS
that's the piece
frente
of
a la
information that
producción, a
the
la
ministry
compra
started
y
to
a la
understand.
distribución de
We
las
have this
pruebas de carga viral
distribution
entre el
of the
país.
viral
Ahora, les voy
load
a
and all of
mostrar la
that. So I
evidencia de
just
los
wanted to
resultados.
show the
Esta es una
experience in the
evidencia del
hospital.
Hospital
This
Regional de
is
Carlos García
what
Tumaco,
we have been
y es
seeing,
el hospital más
and
grande
this
de la
is the
República
largest
Mexicana
hospital
que
in
tiene
social
2.000 camas
security. It has
este
2,000
hospital. Este es un hospital muy
beds in that
completo.
hospital. This is a
Como habrán
very
leído ustedes,
complete or
tiene también
a
programas de
very
emergencia, porque
comprehensive
nosotros asistimos casi
hospital.
3.000
We
pacientes
have
hoy en día
3,000
en
patients,
esta
I would
corte,
say. We have
que es
been
una de
doing
las
that
cortes
from
más
our
antiguas del Perú.
court. It is one of
Recuerden
the
ustedes
most
que
Asian,
Talca,
let's call it
por la
that way,
cercanía del
courts.
centro
We
regional,
have
la más
retroviral
antigua
therapies as
institución del
well
Perú en la seguridad
in
social.
Peru,
Esto
social
fue cuando la seguridad
security.
social
So
comenzó recién en
again, we started in
1997, la primera seguridad
1997
social,
with this
y el diseño de salud
antiretroviral
pública
therapy,
comenzó el año 2004.
and
Pero
in
esto
year
viene de una etapa
2004,
de 7
so
años
we
previos
were
también
in
de
the
la
stage
seguridad
7 years
social
before that as
anterior,
well.
¿no?
In
Porque
addition to what we have
la
been doing,
creación del
we
retroviral
know that this
comenzó a
antiretroviral
desarrollarse
therapy started with
solamente
social
en
security in
este
the Almedara
hospital
Hospitality
y en ese hospital, el
Hospital
Hospital Regional.
and in the
Muy
other
bien,
hospitals. So
esta
again,
experiencia es con 3.000
this is
pacientes
the
en nuestro
experience of
hospital.
this 3,000 patients
Como ven
that we're
ustedes, el
seeing,
80%
and
son
since we
varones,
are
el
working,
20% son
80% are
mujeres, el otro por ciento
men,
varón.
80% are
Nos vamos
women.
a ver
It's
los
a
datos también en
ratio,
nuestro
which is
país.
a 3-to-1 ratio.
Y va, el
And
mecanismo de
then this is the
transmisión es
transmission
parecido,
mechanism that we
con
have.
98%
We
de
have
transmisión sexual.
98% of
La transmisión
sexual
vertical es
transmission, and the
0.8,
vertical
0.3,
transmission is
0.6.
zero point
Acá no
0.6,
hay transmisión
and the
vertical,
cases of
digamos,
vertical
en los últimos
transmission
años
as
han
well
sido
over the past
25
years. It
casos
has been
en
25
nuestro,
cases
en
in
nuestro
our
hospital,
case,
¿no? Y
patients in our
miren, el
hospital.
país, por ejemplo, ha ido
So
recuperando
this
la transmisión
country
vertical de acuerdo a
has
los convenios que han ido
also
pasando. La
reminded
transmisión
us
vertical
that
ha
we
ido
have this
disminuyendo
vertical
por la
transmission that
mejor
has
para su
decreased according
tratamiento,
to the
al diagnóstico precoz, a la
treatment
detección temprana, a
standards,
la aplicación de
early
tratamientos,
treatment,
a la aplicación de
administration
especiales
of
médicos
treatment,
y
and
una serie de medidas
timely
preventivas que se
administration,
dieron
and a
hasta
series of
alcanzar
preventive
menos del
measures
1%
until we get to less than
de transmisión
1% of
vertical.
vertical
Pues hoy en día
transmission.
hablamos de
And
transmisión
today
vertical
we're
de
talking about vertical
0.43%
transmission is
en nuestros
0.43%
pacientes en
of
nuestro
our
caso de
patients
redes y en esta
in
corte
the
de 30.000
hospital, and
pacientes, ¿no?
we have our court with
Pues el
3,000
estatus
patients.
epidemiológico de esta
So we
corte
have
de la
this
seguridad
viral status with the social security. This is very important. 285 patients. Let's see how it all works. We have identifiable how many of them are with over 1 million copies, how many of them have this low degree. This is all very interesting for patients with HIV, and this is something that is consistently just really helping us see all of that. And this is the viral status that we have 2021 and people living with HIV. And this is a program of where we have a cohort, like we said, with 3,000 patients. Here, non-detectable for this last 2022, it was almost 80%. And by 2021, we had 74%. Those who had low degrees, we were talking about 12%. We, in theory, have patients, we have a low count as well. In 2021, we had 18%. So this spiral load for the past year, we also had 9% of this spiral load. And in the past, in 2021, we had 7.7% of this spiral load. Of course, and obviously, an important part of this group where we have this low uh, uh, trend adherence is a very tricky topic. It's something that we need to work on a lot. And the core topic is that patients need to take their medicines. And obviously, when we do not have a way to stop or to have supervised treatment, the only thing to do is to enforce all of the laws by protocol just to try to use this antiretroviral therapy when it comes to the adherence of our patients. Lastly, I wanted to show you these infections. This is something that I want to call, I don't know if another cohorts this is something that happens, and after what it meant, undetectable or untransmissible, non-detectable is non-transmissible. Many of our patients stopped using protection or condoms, and even serodiscordant patients, they're not using condom because they're saying that non-detectable is non-transmissible. Is that we believe that there has been an increase of co-infections such as syphilis. And whenever we have been talking about this cohort, in our cohort we have found 1,908. So out of that, 40% of that, and we have 25%, and we have hepatitis B, cryptococcus, and over here we have lymphoma as well. And there are some other lymphomas that come from infectious causes. However, whenever we see that these are some questions, and this is something we need to really consider, hepatitis B and C, we have streptococcus, and we only have 1%. And it really gets our attention that with these co-infections of our cohort with 3,000 patients with HIV, the most common infection is syphilis, and it's almost 40%. So now, in terms of social security, right now we have been focusing more on the development of an HIV EST program module for hepatitis B so that we can have a set of government unit analysis, data, intelligence. There's a prevention and control board. There's a board where we can see on a daily basis that there's a situational analysis of a patient with HIV. We have age group, we have patients with treatment as well, how many of them are just failing as well, and we have HSV as well. Sorry, doctor. Excuse me, doctor. Do you have 1 minute, doctor? So this is the government unit as well, and well, this is something that we have seen as well, and this is the information, epidemiological information. This is something is just what I wanted to share as well, and well, we have HIV patients as well, and we're only just giving coverage to 25% of our population. Thank you for your kind attention. Thank you so much. Thank you so much, Dr. Cruz Mendervina. We do not have time for a Q&A. My apologies. And Dr. Cruz, and just like everyone else, well, we do have your certificate, and thank you so much, doctor. Thank you, thank you. So thank you. Have a great day. Until next time. Thank you. And now, this is a session. We no longer have a break. We no longer have time. We have another speaker who is already online, and it's time to pass the floor to Mr. Noe, and we're going to continue with his presentation. Thank you so much. So now we will continue with our schedule, and we're just going to continue with now the experience of the Osvaldo Cruz Foundation. And then this is going to be a talk that is going to be headed by Dr. Valdilea Veloso. She is part of this foundation. She is a doctor. She has a master's degree in infectious diseases. She has a doctorate degree in public health. She's a professor of the Osvaldo Cruz Foundation. She is the director of the National Institute of Infectious Diseases, Ewandro Chagres Biocruz, of the Ministry of Health. And Dr. Valdilea has performed as the head of the Department of the National HIV/AIDS in Brazil program, and she is a director of the Department of Health of the state of Rio de Janeiro. And she became part of the Osvaldo Cruz Foundation in 1978, and she has performed a great role in her HIV clinic. Currently, she is the president of the IMPREP project for the implementation of prophylaxis before exposition or men having sex with men and trans people. She has also taken part of the scientific committees and protocol teams to provide care to people living with HIV and the executive committee. So now it's time to pass the floor to Dr. Valdilea Veloso. She is online. So I would like to just please give a round of applause to the doctor. Voy entonces aquí a le pueden ver de buen tamaño ustedes, ¿verdad? Podemos tener nosotros aquí unos problemas técnicos también aquí. Puedo usar la presentación también aquí. Yo sí la veo también aquí. Sí, la vamos bien, no hay problema. También aquí vamos a pasar la siguiente diapositiva. La anterior, por favor. Antes que nada, también aquí podemos ver específicamente lo que tenemos. También aquí estamos en el español. Aquí ha habido un pequeño cambio. También aquí lo que tratamos de hacer también nosotros es, bueno, aquí pusimos español en las diapositivas, pero yo les voy a hablar en inglés. Muchísimas gracias por haberme invitado. Aquí podemos presentar nuestra experiencia. Aquí esa es la presentación, nuestra trayectoria. También aquí al respecto de PrEP, especialmente el proyecto de PrEP en México, en los otros países también que participan justamente en esta situación. Entonces, aquí también nosotros sabemos que la pandemia de VIH es algo que es continuo y nosotros la tuvimos desde 2022, donde tuvimos 30 millones de personas que vivieron con VIH en el mundo, donde 1.3 millones de personas eran recién infectadas.
60,000 deaths.
Y tenemos nosotros más de 60.000 muertes.
As you can see,
Y
in
aquí, como
this
podemos
slide,
ver en estas
in our
diapositivas,
region,
en
we
nuestra
have
región tenemos 2.2
2.2
millones de
million
personas que viven con VIH.
72% are in
72%.
Sahara, and from
Y también a partir
2010
de
without
2010,
2022,
2009 hasta el
the deaths
2022,
reduced to
las muertes se
30%.
redujeron un
However,
32%. No obstante,
we have
tenemos
25%
nosotros
of people
25% de las
presenting here
personas que están
for
presentándose
diagnosis,
aquí para hacer un
and what is
diagnóstico.
more
Y
worrisome
algo que
is
también es algo
that
que nos preocupa muchísimo
in
es
the contrary of
que,
other regions,
al
in
contrario de
our
otras
region,
regiones, en
the
nuestra
new infections
región tenemos nuevas
increased
infecciones
8%.
que aumentaron
That
un
is
8%, es
very
decir, es un
so
porcentaje significativo. Entonces, nosotros vimos que la
in our region
epidemia de VIH
is
en nuestra
something
región
serious.
está descontrolada.
Here we have
Aquí nosotros tenemos... Un minutito, por favor. Aquí tenemos las nuevas
of HIV
infecciones
in vulnerable
del
populations,
VIH en las
our
poblaciones
epidemic in our
vulnerables. Es
region
una
is
epidemia en nuestra
what
región,
we call
que es lo que nosotros le
concentrated
llamamos
hemolytic,
epidemia
with
concentrada. Y siempre
MSM
lo
as
vemos entre los hombres que tienen sexo con
trans,
hombres, mujeres trans
cis
y
are the most
transvestis,
effective.
y son los más
As
eficaces.
you can
Y también
see
aquí
here,
nosotros lo
the new
podemos
infections
ver
from
aquí las nuevas
vulnerable populations,
infecciones de las poblaciones
48%
vulnerables,
are men
48%
when have sex with
de hombres que
women,
tienen sexo con hombres
60%
y un 6%
trans women,
de mujeres trans
and 29%
y
among
29%
clients
entre
of sex
clientes de las sexo
and
trabajadoras o trabajadoras del
artisans of
sexo
people groups.
en ciertas
For
partes de la
example,
población clave.
people who
So
inject
we have
drugs
this
is
percentage of people
6%
who
of sex workers.
consume injected drugs.
Here is
And
a
here
systematic
we
review,
have a systematic,
and you can
aquí tenemos
see
una revisión
how
sistemática y aquí podemos ver
monthly is the local
cómo es que
age
nosotros estamos viendo
infections
aquí
in
la
our
edad de
region.
las infecciones en
This is
nuestra
the
región.
prevalence
Esta es la
of
prevalencia que
HIV
tenemos del
among
VIH
NS.
entre los hombres que tienen sexo con hombres.
Aqui registramos esse.
Aquí llegamos a un 30%.
Here
Aquí
you can see that
podemos
among
observar que entre
trans women,
las
the
mujeres
load is
trans
even higher.
la carga incluso
You
es
can see
mayor. Podemos ver
that,
aquí
for instance,
que de
in several
hecho
countries,
en varios
the level
países
of
la
HIV
prevalencia
infection
de las
among
infecciones por VIH
trans
entre
women is
mujeres
very high.
trans
For instance,
es
in Brazil,
muy
in
bajo. Por ejemplo, podemos ver
Bolívia,
en
in
Brasil,
México, El
México, El
Salvador,
Salvador,
Uruguay, Argentina,
Uruguay,
Peru,
Argentina,
and many
Perú,
places we don't
muchos
have
lugares no
data.
tenemos
But
datos,
the data we
pero
have
los datos que
indicate
tenemos nos
that
indican
the load is
que
very
la
high
carga es muy
among
pesada
trans.
en mujeres
Here we have the
trans.
incidence
Aquí tenemos la
of HIV
incidencia del
per
VIH
1,000 persons.
con
Uh,
1000 personas,
Previous
digamos que
for
es la
2030,
previsión para
the net
2030 y la meta para la eliminación
AIDS
del
infections.
SIDA en
You can
América Latina
see
y el
that
Caribe.
we are
Podemos ver que estamos muy lejos de esa meta si las cosas continúan hasta como
you
ahora.
see the incidence,
Podemos ver la
and I
incidencia
can show you
y
here
les voy a
what
mostrar
studies
aquí
we
uno
have
de los
conducted
estudios que hemos llevado a
in the umbrella
cabo
of the PrEP, that
en el
is
paraguas del PrEP, que es el consumo que hemos comenzado en Brasil, México y Perú. Tenemos una incidencia de 30 y podemos ver aquí que se llevó a cabo en Brasil y en Perú. Y también podemos ver aquí las ciudades en donde tuvimos algunos lugares para este estudio. El estudio se llevó a cabo con una muestra de MSM y mujeres trans que estaban buscando una prueba de VIH y utilizamos estos, estas pruebas para calcular la incidencia. Aquí nos aproximamos a 7.362 personas y casi 7.000 fueron elegibles para estar enroladas, el 67% en Brasil y el 32% en Brasil, en Perú. Y aquí podemos ver que la incidencia es alta. En Brasil 2.62 y en Perú 6.69, lo que es una prevalencia bastante alta. Y cuando vemos los datos de la edad, podemos ver que entre más jóvenes, digamos de 18 a 24, tienen la incidencia más alta. En general, de 25 a 32, el 3.42 y en Perú 9.77. Como ustedes saben, tuvimos varios ensayos clínicos evaluando el Tenofovir y Entrecipán para la prevención de la adquisición del VIH. El primero fue la IMSS y eso se llevó a cabo entre MSM y mujeres trans, que ese fue el ensayo de registro y este nos mostró la eficiencia de el PrEP para el VIH. Después del PrEP, algunos otros estudios se han hecho en la población y también nos mostraron la eficiencia y seguridad entre hombres heterosexuales, mujeres heterosexuales y también estos son algunos estados, principalmente nos muestran dónde estamos. Podemos continuar, por favor. Entonces, ¿pueden pasar a la siguiente diapositiva, por favor? Oh, bueno, aquí podemos ver esta diapositiva, el impacto, podemos ver la incidencia del VIH entre 1.000 personas y podemos ver aquí que estamos lejos de la meta de 2030. Y aquí les voy a mostrar los resultados de un estudio de cero incidencia. Los datos de incidencia no son comunes en nuestra región, entonces llevamos este estudio de cero incidencia en el paraguas del estudio de IPREX y se llevó a cabo en Brasil. Por favor, la que sigue. Podemos ver las ciudades en donde llevamos a cabo el estudio y la población era una muestra conveniente de NSM y de mujeres trans que estaban buscando pruebas de VIH. La siguiente, por favor. Podemos ver que hemos llegado, alcanzado casi a 7.500 personas y casi 7.000 de ellos se enrolaron, 67 en Brasil y 33% en Perú. El siguiente, por favor. Aquí en esta diapositiva podemos ver cuán alta fue la cero incidencia entre la población que enrolamos. En general 32.8, 2.62 y 6.669 en Perú. Y estas diapositivas también podemos ver la edad de entre 18 y 25 años, que la incidencia general entre los pacientes más jóvenes fue de 5.32, en Brasil 3.48 y en Brasil llegó hasta un 9.77. Podemos ver que hay un gradiente en esta cero incidencia de acuerdo con el rango de edad. Siguiente, por favor. En esta diapositiva podemos ver los resultados de los ensayos clínicos principales que evaluaron la seguridad y eficiencia del PrEP con renofovir y entrecitata. El primero fue el IPREX, que se llevó a cabo entre hombres practicando sexo con hombres y mujeres trans. Y vemos que ellos fueron la población más afectada en nuestra región. Siguiente. Este estudio, el PREX y los otros estudios mostraron la eficiencia y seguridad de la profilaxis preexposición de HIV y el valor fue aprobado por en 2012. Siguiente. Tuvimos la oportunidad de participar en el estudio IPREX y aquí podemos ver el monitoreo de la implementación de este prueba y podemos ver aquí el azul oscuro son la implementación más alta, el número alto de la iniciación del PrEP. Podemos ver que en nuestra región varios países se encuentran con un número bastante bajo de personas que hayan iniciado con el PrEP. Siguiente, por favor. Siguiente. Aquí podemos tener la meta o podemos ver la meta para la PrEP. Aquí tenemos y podemos ver que estamos muy por debajo de la marca. Podemos ver a la derecha lo que se espera para 2025 y si continuamos en esta base no vamos a llegar a la meta a 2025. Siguiente, por favor. Aquí tenemos la implementación del OroPrep. Podemos ver las regiones. En los cuadros rojos tenemos a América Latina y podemos ver que estamos muy lejos de la meta. Siguiente. Aquí tenemos otra representación y vemos que la cobertura es bastante baja, no llega a más del 5% de las personas que requieren una PEP la obtienen en nuestra región. La mayoría de las personas en PrEP, aún incluso en Brasil. Eh, siguiente. Siguiente, por favor. ¿Pueden regresar una, por favor? Regresen una, por favor. Por favor, regrésenle. Sí, bueno, la que sigue. Podemos ver en esta diapositiva que tenemos la publicación de este documento y que, como les dije, fue un estudio que mostraba la eficiencia y seguridad de la PrEP. Siguiente, después de la aprobación de la trufada como PrEP, comenzamos a llevar a cabo los estudios de demostración que llamamos que el PrEP, como lo llamamos como PrEP Brasil, porque entendimos que teníamos que ver si esta estrategia o tecnología habría de funcionar en nuestro sistema de salud. Entonces hicimos este estudio y tuvimos 450 participantes y tuvimos resultados bastante buenos. Siguiente, por favor. Siguiente. Y bueno, los estudios, eh, no solamente hicimos los estudios de demostración, sino también tuvimos un estudio de costo efectivo, de costo y efectivo con nuestro sistema y después de ello decidimos incorporar el PrEP. Nos tardamos un poco en hacer disponible el PrEP al comienzo de 2017 con nuestra guía. Siguiente, por favor. Entonces, con base en esta experiencia, tuvimos la oportunidad de establecer una alianza entre Brasil, México y Perú para llevar a cabo estudios para generar evidencia científica que nos pudiese apoyar al Ministerio de Salud en México y Perú para decidir sobre la prevención y la incorporación de la PrEP como componente de las estrategias de prevención. Y bueno, el proyecto se eh, aprobó y tuvimos la oportunidad de llevar a cabo, la que sigue, por favor, en fondo por algunas otras asociaciones y con la contribución del Ministerio de Salud de Brasil, México y Perú, tuvimos la oportunidad de llevar a cabo varios estudios y como podemos ver aquí, este es el paraguas del proyecto IMPREP. Llevamos a cabo encuestas, estudios cualitativos, económicos, de cero incidencia, como les mostré al comienzo, ensayos distritales y un modelaje, así como también ensayos clínicos sobre la distribución secundaria de estas pruebas. Siguiente, por favor. Aquí voy a mostrarles los proyectos más importantes que hemos llevado a cabo. Ese es el Paraguay y ese fue el estudio de demostración de el mismo día de la iniciación de la PrEP que llevamos a cabo de febrero de 2018 hasta diciembre de 2021. Fue un estudio de demostración, una perspectiva, con perspectiva multicéntrico para evaluar la aceptabilidad y posibilidad de ofrecer y comenzar con la PrEP con el mismo día de los tratamientos. El siguiente, por favor. Aquí tenemos los países y también las ciudades en donde llevamos a cabo los estudios de demostración. Siguiente. Aquí tenemos los procedimientos. Llevamos a cabo el reclutamiento. Primeramente, estábamos buscando, llevamos a cabo pruebas rápidas de VIH, dependiendo de los resultados para poder comenzar con la PrEP, porque fue una estrategia del mismo día, pero para poder ver los resultados en unos cuantos días y la carga viral, si era positiva, entonces habríamos de llamar al participante para comenzar con el tratamiento retroviral. Y en ese momento esa fue una preocupación, pero ahora ya no lo es. También recolectamos sangre para su función renal y también pruebas rápidas de sífilis y hepatitis B y C y una, una muestra anal para neumococo y clamidia. Y los participantes y su reclutamiento se les dio una botella de PrEP con artículos para 30 días. En 30 días los revisamos, teníamos una visita programada para ver los tipos de resultados y recolectar también sangre en una tarjeta para evaluar los resultados. Y después, cada 3 meses, una visita y una prueba de VIH, de sífilis, y luego, después, en el tercer día de visita, el participante comenzó a recibir suplementos de un PrEP para 3 meses. Siguiente. Aquí tenemos el flujo del estudio y podemos ver que evaluamos cerca de 10.000 personas, entre mujeres trans y hombres que practican sexo con hombres, y comenzamos con 9.552 y excluimos algunos por una infección aguda. Eh, Excluimos 43 que resultan muy pocos entre 9.509 participantes que continuaron en el estudio. Fue muy bajo en realidad. Entonces una infección aguda, si vemos algún síntoma, esos síntomas no son una preocupación para comenzar con el PrEP. En México empezamos con 2.808 participantes. ¿Sí? Siguiente, por favor. Aquí en esta diapositiva vemos las características de los participantes que fueron incluidos en el estudio y podemos ver que la mayoría, la grande mayoría, fue la población de sexo que practican sexo con hombres, pero también cuando vemos el 60% entre de las mujeres trans, el porcentaje es bajo, pero el número absoluto es alto. Fue el número más alto de mujeres trans que fueron reclutadas en este estudio de demostración. Después, bueno, reclutamos mujeres jóvenes o personas jóvenes y podemos ver que 58% de los participantes estaban en la faja de edad de 18 y 30 años de edad. Uno de los problemas que continúa siendo un problema con relación a la implementación de la PrEP en muchos lugares del mundo es que el 81% de los participantes fueron personas con una educación secundaria o menor. Es decir, con personas con menor educación no se involucraban en, en, en la proporción adecuada en el estudio. Podemos ver que la mayoría de los participantes buscaban la PrEP. Eh, Iban a los centros de salud y hablaban de sexo anal sin condón y el 6% 66 usaba alcohol y 18% utilizaban estimulantes. Aquí tenemos un 42% en Brasil, 7.9% en México y 16.3% en Perú. Entonces, la continuación es cuando la persona era reclutada y no venía a ninguna visita después de esto. Entonces, ¿quién? Bueno, aquí tenemos 8.4% de los participantes no regresaban a sus visitas después de haber sido reclutados. Entonces, aquí tenemos los factores asociados con
And you can
la
see that we
discontinuación
have
temprana y podemos
massive.
ver que, bueno, la que sigue, por favor.
You can see here
Podemos ver aquí
that
que el
8.4%
8.4%
didn't come to a
no
health
regresó, no
any
fue
visit
a ninguna
after
visita
the
después
deployment.
de haber sido
It
reclutado.
disappeared.
Se
And here we have
desaparecieron.
the
Y
effects
aquí tenemos
associated
los
with the
efectos asociados o
public
los factores
situation. You
asociados
can
a esa
see
discontinua,
the
a esa...
importance
eh,
of education. You
podemos
see
ver
that
aquí que la
crime
educación es
in preternatal
importante.
visits was
Aquí
2.20,
podemos ver
one of the
que es el
highest
dos.18,
related
es una de las más grandes y más
after the
altas
IMSS
porcentajes
uh, act.
en cuanto a un factor en el país.
And you see the also even
Y también
federal
podemos ver que incluso
police
con
intervene
la
in
secundaria
deciding
completa
if the
o sin completar,
domestic
es un factor
gun
asociado
discontinuation
con
when you compare
el
with people with moderate
abandono de esos
visits to secondary
tratamientos
education.
en
The,
relación con las personas con una educación
this
mayor a la secundaria. Entonces,
gap argument is
aquí
because
tenemos un error en
for
esta
the
diapositiva
definition
porque la
here
definición aquí
of
de
gun discontinuation
el abandono
is emphasized some places.
precoz en la parte superior no está
But the
correcta,
correct definition
sino
has
que la definición
people that
correcta es
didn't
personas que
show up
no se
after
presentaron
the inclusion. You
después de
see
su
one
inclusión.
problem that the
Revisieron
nexus.
una visita y después ya nunca más se presentaron.
Here we have the
Aquí
study.
tenemos el estudio, el
Continuation is what we want.
abandono,
It's what we want to have
lo que
to
queríamos era tener
continue for
una
long
continuación por un gran
visits.
periodo, un largo
Here
periodo
we
usando
have
el PrEP. Y aquí
the data
tenemos los datos
for Brazil,
de Brasil.
81.1%, Mexico 68%, and Peru
81% en
51%.
Brasil,
Next,
52%, 52.8% en Perú. Siguiente.
you can see here that
Podemos ver aquí
70%
el
overall of
70% en
the
general de
participants
los participantes
has long-term
presentaron o
adherence
tuvieron una
for
adherencia
the
de largo
intervention.
plazo
One point
al
that I would
tratamiento.
like to highlight
Un punto que me
that
gustaría
among the
señalar
factors
es
that we
que
see in
uno
the
de los
right
factores que vemos a la
that is
derecha
associated
están
with long-term
asociados con
commitment
un compromiso a largo
is the
plazo, es
self-report.
el
In the week 4,
autoinforme.
we asked the
En la
participants
cuarta semana les
if
pedimos a los
they
participantes
took all
si
treatments. And
se habían
those
tomado
that
todas las
reported that they
medicinas y
took
esos que
all
dijeron que se habían tomado todas las
had
píldoras
most, the
tuvieron
highest chance of
la
obtaining
oportunidad más grande o más importante
uses
de
that
continuidad en el
above
uso del PrEP,
52
por
weeks
arriba de
of follow-up.
52
You can see
semanas de
that it's
seguimientos.
the
Podemos
most
ver
important
que es el factor
because
más
this is the
importante.
indicator that
Entonces,
we can
eso nos
use
indica que
in our
podemos
clinical
utilizar en
test.
nuestra
We
práctica
can ask the
clínica,
self-report
podemos
of the
pedirle
patient,
el
is reliable,
autorreporte de
and
adherencia, es
should be used.
confiable
If the
y debemos
person
utilizarlo. Si la
report
persona
not that have not
informa
taken
no haber
all the pills,
tomado
we
todas
should
las
address
píldoras,
the
deberemos
problem, the difficult, the very
llevar
difficult
trabajar con
here
las
we have
barreras o
the
las dificultades que
characteristics
nos
of
causan esto. Aquí tenemos las características
people.
de las
You
personas,
have the people
tenemos
and
las
we have
personas y también tenemos
overall 68%
en lo
of
general
the
el
participants
68% de los
has
participantes
good adherence.
tuvieron una
What
buena
we call
adherencia.
adherence?
¿Qué es lo
The,
que llamamos
the
adherencia? Bueno, adherencia es que estemos
medication
utilizando los
consumption rate
medicamentos,
for
las
the formula
tasas
is here.
que tenemos aquí en esta
The number of
fórmula,
weeks
el
the patient
número
has
de
been given
personas que
in
tuvieron
order
en
to take.
posesión las
So
medicinas para poder tomarlas,
68%
el
of the
68% de los
participants
participantes en
had
PrEP
a medication
tuvieron
consumption rate of
una tasa de posesión de
0.6.
medicamentos de un
That is equal
0.6.
to
Eso es
4
igual a
pills
4
per minute.
píldoras por semana.
Medication amount of 4 pills per minute. That
Medicamento
is
de
the
4 píldoras por
number of
semana. Ese es el número de
that
píldoras que
provides
nos
good
da
protection,
una
high,
buena
high
protección,
protection.
alta
You can
protección.
see that among
Podemos
transgender
ver
women, it
esto
is
entre las mujeres
80 hours
trans.
lower
y entre los hombres que practicaban sexo con hombres era menor, con un 47%. Y aquí tenemos la tasa de incidencia por persona por año y aquí podemos ver que tenemos una gradiente. En general 0.5% y aquí tenemos una gradiente de Brasil o en Brasil y Perú. ¿Podemos continuar, por favor? Siguiente. Bien, aquí podemos ver, vamos a observar en la siguiente diapositiva la incidencia. Y también podemos ver aquí, bueno, la incidencia que se correlaciona muy bien con la proporción de participantes en el estudio que tuvieron una buena tasa de consumo de medicamentos. Y podemos ver que esa tasa está próxima a la adherencia. Lo podemos ver aquí. México, Brasil y Perú. Tenemos ahí una gradiente. Siguiente, por favor. Y podemos ver aquí la gradiente que se muestra aquí. En general tenemos una incidencia de 0.85 con Brasil, la menor en Brasil y con una mayor incidencia. Siguiente, por favor. Podemos ver aquí en esta diapositiva que la incidencia en el estudio fue mayor entre los más jóvenes, entre las personas con una edad de entre 18 a 25 y aquí podemos ver la mayor incidencia. Siguiente, por favor. Aquí tenemos estos datos que ya les mostré al comienzo. La incidencia en Brasil y en Perú podemos ver que sin la PrEP la incidencia es mucho mayor. Podemos ver un 2.62 para Brasil, 6.69 para Perú. Es mucho más alta que los datos que obtuvimos en el estudio de demostración con el uso de PrEP. Siguiente, por favor.
La carga que tenemos nosotros aquí de enfermedades de transmisión sexual la podemos ver aquí por país. Vemos aquí la prevalencia del sífilis. Brasil tiene la prevalencia más alta, 11.4, y aquí podemos ver que en México y en Perú también es bastante alta. Aquí tenemos una demostración del problema que se presenta. Bueno, la siguiente, por favor. Aquí tenemos, aquí se puede ver que cuando vemos la prevalencia de clamidia y la gonorrea, también aquí vamos a ver una molécula que también se puede diagnosticar. Aquí la carga también es muy importante. Pero el punto que quiero destacar aquí es que, basado en nuestros resultados, aquí también podemos ver la prevalencia en el desarrollo y también podemos ver esto. Podemos ver la prevalencia, que la prevalencia no aumentó. Podemos decir que el riesgo de compensación que se relaciona a lo que se asocia como el uso que tenemos, por lo menos en América Latina, en Brasil, México y Perú, nuestros datos no están de acuerdo con nuestros datos y con lo que las personas antes solían decir. Suelen decir que las personas que usan PrEP aumentan la incidencia que también se tiene de las enfermedades de transmisión sexual. También aquí lo que se ha demostrado en PrEP. Aquí una preocupación. También aquí, antes de empezar nosotros con PrEP, también aquí el resultado, también aquí Hicimos aquí el análisis, también aquí vamos a ver. Aquí lo que no vimos, también aquí vamos a ver principales problemas, también aquí con la función que tenemos en las personas que están utilizando PrEP. Entonces aquí podemos también nosotros, tenemos algunas excepciones, personas que también tienen este tipo de situación, bueno, podemos empezar con ellos PrEP de forma segura, sin tener que esperar los resultados que nosotros estamos viendo. Entonces, siguiente, por favor. Aquí se está publicando, es un mensaje de VIH. Aquí me da mucho gusto, aquí también ver que tanto Perú como México ya incorporaron PrEP en su estrategia de prevención para el país. Siguiente, por favor. Entonces, ¿cuáles son las lecciones que estamos aprendiendo aquí? Siguiente. Pero bueno, aquí pasa con PrEP el mismo día, básicamente desde el principio. Vamos a ver qué es lo que se está autoinformando en la semana 4. Es un gran aspecto para predecir a largo plazo esta adherencia a PrEP, pero no aumenta con PrEP. Y tenemos nosotros también que ver estos determinantes sociales, por ejemplo, también qué es lo que pasa que se tiene una baja una adherencia, lo cual también aumenta. ¿Qué es lo que pasa también cuando nosotros podemos ver esto en otro nivel? También aquí lo que vemos, lo vimos también así. Estos datos son más difíciles de lograr, de alcanzar y también se hace. Es mucho más difícil también nosotros considerarlo como parte de PrEP. Siguiente, por favor. Y también tenemos nosotros que ver las estrategias a nivel cultural, también aquí lo que se está adaptando para poder nosotros poder ver cómo podemos nosotros mejorar el acceso y usar PrEP para que también podamos reducir nosotros cualquier tipo de disparidad en el acceso de PrEP con VIH-Sida. Y aquí otra cuestión muy importante es que cuando se tienen evidencia robusta, científica, todo puede impactar en las decisiones del Ministerio de Salud y también para el uso para poder formular nosotros las políticas de salud pública. Siguiente, por favor. También aquí nosotros dimos una encuesta que se hizo. Nosotros aquí llevamos a cabo en Brasil, también en Perú, usando también Facebook y lo usamos con los hombres que tienen sexo con hombres, gay, bisexuales y otros hombres que tienen sexo con hombres. En el 2018 y en el 2020. Siguiente, por favor. Aquí podemos ver nosotros que casi tenemos a 2.000 personas que están evaluando la encuesta, la respondieron en el 2016. Siguiente. Acá tenemos el resultado de nuestra conciencia y disposición para usar las cosas. Tuvimos nosotros también un aumento de 80 a 21, pero la disposición de utilizarlo en este momento no aumentó en Perú ni en México. Y también fue debido a que PrEP no estaba siendo una variable en Perú ni en México en el 2020. En Brasil esta disposición aumentó probablemente porque estaba disponible también el sistema de salud pública. Tenemos también otras publicaciones, también con estos resultados. Siguiente. Aquí tenemos entonces aquí las nuevas tecnologías. Tenemos más adherencia también aquí. Entonces aquí también lo vimos también. Aquí tenemos que contribuir también para ver los resultados que vemos también aquí a ver. También aquí para ver qué es lo que hacemos todos los días. Básicamente aquí lo que podemos ver es que tenemos también nosotros aquí dos estudios principales, HPM 04H, también también aquí sobre todo qué es lo que tenemos y cómo se administra. Y también aquí si tenemos estos estudios también aquí nos muestran también aquí. Nuevamente también aquí podemos ver esta VIH también en comparación con lo que tenemos aquí. Siguiente, por favor. Aquí tenemos entonces el estudio que se publicó. Siguiente. También se aprobó. Siguiente. Fue aprobado por la SDA en el 2021. Siguiente. Y también aquí tenemos los lineamientos de PrEP que se encuentran disponibles. Siguiente. Y también en IMPREP también estamos preparando nosotros para una implementación de acción larga. Nosotros nos hicimos una encuesta donde tenemos a MSM y también trans. Y también vimos estos inyectables. También aquí 75% de los participantes informaron para hacer este PrEP inyectable. Siguiente. También hicimos un experimento donde se hacía una opción y también donde se determinó que las personas respondieron a las preguntas, participaron también en este estudio y también nos ayudaron también a ver los PrEPs inyectables en otras formas también aquí de acción larga. Ahora ya vamos a empezar a tener, ya empezamos nosotros en Brasil y empezamos un proyecto de demostración donde tenemos 1200 NSM también, personas no binarias, donde los objetos también son también aspectos que podemos elegir como parte del sistema de salud brasileño, las personas que están teniendo acceso, la población está aquí, tenemos aquí los participantes, también aquí tenemos aquí el PrEP y tenemos aquí 6 centros en Brasil. Aquí las personas que también están, las personas que han sido elegidos, si todo el mundo está con autoprep y para ver si prefieren tener más inyectables, este tipo de integraciones. También nosotros tenemos varios objetivos secundarios que han generado evidencia para que podamos nosotros apoyar a la salud en las decisiones que tenemos sobre la incorporación. También vamos nosotros a llevar a cabo un estudio también de causa y efecto. Siguiente. En estas diapositivas podemos ver que es una tabla que nos indica los países donde nosotros tenemos esta participación y cómo tenemos nosotros también aquí para tener nosotros esta licencia. Industrias, también aquí que estamos nosotros aquí produciendo también en la cabina. Entonces, Aquí en azul
those countries that will be able
tenemos
to
estos
compare
países que van a poder
genetically
también comprar de forma
and
genérica.
VGX will have lower
Y
price.
genética, bueno, podemos
And
ver esto.
also
Entonces también
the countries
tenemos
in
aquí
orange,
los
that are
países.
countries where the patent of carboxygraphy was not
Y aquí vamos a ver que el país
applied,
no estaba
they
aplicándolo.
will also be able to purchase
Y también vamos a
our
poder
genetic
nosotros
for a lower
simplemente
price
poder seguir con
as well.
otro
But
precio.
regarding Brazil and
En cuanto
Mexico,
a
we
Brasil y
can
México,
see that we are in gray. Gray countries
son
will
excelentes
not be able
países los
to
dos y aún así no.
benefit from the lower price for genetic
También aquí
carboxygraphy.
tenemos nosotros aquí
That
nosotros
is
una integración
totally
y eso
unfair.
sería básicamente algo
Next,
que
please.
podemos ver siguiente.
Some challenge for
Tenemos
Brazil.
algunos
We can
desafíos
see
para Brasil.
here
Aquí
that
podemos ver
Brazil has
nosotros que
now
Brasil ya tiene
852 centers
853
offering
sexos
PrEP,
que
and around
ofrecen
70,000
PrEP.
people on
Son los
PrEP
distintos
right
centros
now, which is
que se
very low
especializan
number
en enfermedades de
considering
transmisión
the
sexual. Y también aquí
Brazilian
tenemos a
population.
la población brasileña
For
en
you to have
ICE.
an
También aquí, para
idea,
que
we
tengan
have
una idea, también nosotros
seven,
tenemos
uh, seven
7
hundred thousand
cientos
people
mil
on
personas
antiretroviral
que
treatment.
están con este tratamiento
Next.
retroviral.
See the
Aquí
new
podemos ver nosotros
people
también
starting
aquí
PrEP
a las
along
nuevas
the
personas que
years,
empiezan con PrEP.
which is increasing
Y
but
también está
it's
aquí
still a
aumentando
very
también el
low
que el
number
presupuesto
for
sigue también
our
siendo bastante
reality.
bajo
Next.
en cuanto a la realidad.
71%
El
of the people
31% de las personas
that have at least
que por lo menos
one
tienen
dispensation of
aquí
carboxygraphy in the last
esta
12 months,
que tenemos también aquí en los últimos
12
documentos
in
también se ven en PrEP
September
el 20 de
2023.
septiembre de
What
2023.
it means that
¿Esto qué significa?
29%
Que
of people
29%
that
de las
started
personas
PrEP
que
in the
empezaron con
last
PrEP
12 months discontinued PrEP.
también no tuvieron una
Next.
descontinuación de PrEP. Siguiente.
The average of use was 240 days. Next.
Nuevamente también podemos ver aquí qué más se puede hacer.
You can see
Aquí podemos ver nosotros,
82% of the
aquí
people
82%
using
de las
PrEP
personas que
are
utilizan
gays
PrEP,
and other men who have sex with men.
hombres que tienen
And
sexo
as
con hombres.
I showed before,
También, como
the
ya lo mencionamos antes, también
education,
aquí tenemos la educación.
72% of the people using
Tenemos
PrEP
aquí las
now
personas
in
que
Brazil
utilizan PrEP, también en Brasil.
have 12 or more years of education. And so it's a problem.
Es un
We
problema,
need to
entonces
address
aquí tenemos
people
nosotros que ver a las
more
personas,
vulnerable, socially
también
more
sobre todo para que sea
vulnerable,
más
in order
vulnerable
to
también aquí
increase
y también
access
para
to the
aumentar nosotros el
benefits
acceso y los beneficios
in
de
our
PrEP
population.
en
Next.
nuestra población. Siguiente. Siguiente.
Here is the experience of our service. We started our service
Aquí vamos a empezar
service
también con los servicios de y nos
and
centramos
it
más en
was
los
a very
médicos.
good because we don't have enough physicians. And so during the
Entonces aquí durante
COVID
la
pandemic,
pandemia,
we
sobre todo de
started to
COVID,
use telemedicine for PrEP.
y sobre
And
todo lo que
in
tenemos aquí
self-test.
PrEP, entonces aquí
It
tenemos este
was
texto, también
very
aquí,
successful.
también, bueno, fue muy exitoso.
We have the experience, we have two
Aquí tenemos nosotros aquí dos, tenemos el resultado de los artículos.
about using telemedicine, acceptance, and also
Telemedicina, también
the
aquí,
results of the use of telemedicine
también aquí
and,
de la
and
telemedicina,
self-test. And based on this
también
experience,
aquí
and
en nuestra
also with a
experiencia,
new regulation in
aquí
Brazil
una nueva
that
disposición
allows
de Brasil.
no nurses and
Tenemos
pharmacists
también aquí
to
enfermeras y farmacias.
prescribe PrEP, initiate and prescribe
Entonces,
PrEP.
sobre todo para poder
We
empezar a recetar también PrEP. Y
incorporated a
nosotros
new
hemos
model
incorporado
of
también aquí un nuevo módulo.
PrEP services in ex-Fiocruz. You can see here that is a prescription for our nurse.
También aquí sobre todo lo que podemos ver.
Here in Brazil, the
Aquí
proposal
también aquí
in light,
lo que podemos ver.
live streaming, you see the PrEP that are prescribed by
También aquí lo que
pharmacists
podemos ver es
all
lo que ha
over
también
Brazil.
visto también
Next,
aquí.
along the years.
También con el
And
paso de los años. Y
in our
también
service,
Aquí en nuestro servicio, también aquí nosotros podemos ver que ahora la mayoría de las prescripciones de PrEP están hechas por las enfermeras. Nuestras enfermeras también pueden empezar también a poder prescribir PrEP. Los médicos también se les llama si hay algún tipo de problema de seguridad, de alguna queja. También aquí es muy importante también mejorar la disponibilidad de PrEP en nuestra ciudad. Aquí tenemos esta estructura que es bastante sencilla, es una estructura muy simple. Y aquí también tenemos una estructura bien sencillita. También aquí para los participantes, para los usos que quieren mucho también aquí. Y un día antes también aquí tenemos los resultados también que estaba viendo, también a partir aquí en WhatsApp, también aquí. Aquí la prescripción también está aquí, así simplemente cuando llegan, aquí estamos nosotros viendo sífilis, también aquí, sobre todo que es lo que vimos, también en la prueba de SSI, sobre todo para la prescripción. Entonces, bueno, aquí vamos nosotros a acabar. Lo que quiero hacer es simplemente destacar que el principal activo también así, con la homofobia, también aquí estigma y discriminación, sobre todo aquí con la pandemia, sobre todo que tenemos, también aquí especialmente en la región, sobre todo para acabar nosotros con las infecciones de VIH-Sida. También aquí nosotros vamos a querer agradecer a los patrocinadores. También aquí más participantes del estudio. También aquí, la siguiente, por favor, centros de salud. También aquí nosotros podemos ver esta presentación. Muchas gracias a todos los que me ayudaron con la presentación. Y gracias. Muchas gracias, querida doctora Veloso. Me gustaría ahora abrir el micrófono para preguntas. Quizás aquí, desde nuestros lugares. Gracias, doctor Iván. Doctor, do you need me to keep in Spanish? Yes, I can understand. So Brazil. Instituto Mexicano de Seguridad Social institution, but we have the challenge of just implementing everything. What has been your experience and how complicated it was? That first contact just could really take this time. Yes, I can understand what has been having your results. First contact physicians as well. They just really wanted to just really report everything as well. We have this paradox, this competition. So we have an expert. So how is it that we are going to facilitate this
This
situation?
was what with the experience
Con la
of
experiencia
actually
que tenemos nosotros al momento de
managing
ofrecer PrEP,
PrEP users, we
sobre todo con los
easily,
usuarios de PrEP, también nosotros fácilmente
quickly
podemos
find
ver
out that
rápidamente y
it was
podemos ver
not
específicamente lo que
necessary
fue, no solamente necesario para tener nosotros
the
ese
time
tipo de
of physician
déficit y con
use it
los médicos también lo utilizan también para administrar, también aquí esto que
uh,
tenemos esto. Sería muy costoso también aquí. Tenemos aquí también las actividades más complejas y durante aquí con los estudios también nosotros podíamos entrenar también aquí a los médicos de capacidad también aquí, sobre todo a las enfermeras, médicos y también para tener nosotros a personas no expertos en VIH, que normalmente estaban ellos ahí haciendo estaban recetando PrEP como tal. Entonces a veces puede ser fácil y a veces se puede hacer así, pero en nuestra ciudad, al menos en la ciudad de Río de Janeiro, el Departamento de Salud también ya descentralizó PrEP para la atención médica primaria. En toda la atención médica primaria y todas las instalaciones de este tipo de atención médica podemos tener también PrEP y nosotros ofrecerlo y poderlo dispensar sin ningún tipo de control, sin ningún tipo de problema. E inclusive para aquellos que no son médicos, enfermeras, farmacias, PrEP puede también ofrecerse, se puede controlar, se le puede dar seguimiento de manera muy exitosa. Entonces, bueno, nuestro sistema de salud no tiene que tener que usar el tiempo del médico para poder recetar cada botella de PrEP. Los médicos tienen que adaptarse, pero para casos más complejos, para las personas que también tienen este tipo de comorbilidades, personas que tengan problemas con eventos adversos, simplemente eso es lo que ocurre. Pues aquí la mayoría, la gran mayoría de las personas no tienen ningún tipo de problema usando PrEP, entonces nosotros podemos ver aquí en PrEP que sí es seguro, es muy seguro. Y la descentralización también tiene también aquí, tiene este tipo de contribuciones o aportaciones para poder acelerar y ampliar, sobre todo para PrEP, para nuevos candidatos de PrEP. Y también, de hecho, es muy importante, los sistemas de salud también tienen que funcionar y para tener todo un potencial. Y normalmente los médicos dicen no, los médicos son los indicados, también los médicos dicen no, necesitamos nosotros aquí a los expertos de VIH, necesitamos personas también aquí que nos pueden ayudar a entender PrEP y tienen que estar con las personas que simplemente puedan estar trabajando en ese sentido y también que sea muy importante para que podamos nosotros tener mayor salud. Aquí es algo muy importante tener esta especialización. Nuestra experiencia también ha sido esa. Thank you very much. You're always welcome in Mexico. So we hope that we can really be with you in person. So thank you so much for taking part as well. Gracias, al contrario. Thank you. So I just wanted to ask if there's any other comment that we would like to add. So, Dr. Valdilea, once again, I just want to thank you for your valuable participation and also thank you for the comment of Dr. Ivan Martinez to just really strengthen that invite to just really work in person here at home in the Inter-American Social Security Conference. This is your home, and also to develop maybe a workshop where you can just share the experience directly so that we can really reinforce the strategy that the Social Security Institute has regarding PrEP and PEP, and also the Inter-American Conference of Social Security as well to have more incidents and in all countries that are part of the institutions of the Inter-American Conference of Social Security. So I just wanted to really share a certificate for your valuable participation, doctor. So I'm going to just really send all of this and we're just going to greet you all, Mr. Soya Burto and our General Secretariat, Mr. Alfaro Pelarca And well, thank you so much for your participation. And we would like to give you a big round of applause. So thank you so much. Thank you.
Okay, for you whenever you need. Thank you very
Aquí
much.
estoy a su disposición cuando gusten. No, al contrario, gracias a ustedes. And just to finish with our participations, at least in this room, regarding with this social and policy program. This is a keynote speech given by one of the organizations that is heading this strategy to fight HIV and AIDS, which is PAHO and the World Health Organization, WHO. And to give this presentation, I will pass the floor to Mrs. Vanessa Starivnowski, who is going to be our Executive Director on Research Studies here at the Inter-American Social Security Conference. So please go ahead, ma'am.
Muchas gracias, doctor.
Thank you so much, doctor.
Bueno, sí tengo yo
So
algunas
yes, I
preguntas
have the great pleasure of
sobre
presenting
nuevas
Mr.
informaciones. He
Gasagestumen
sido
as well,
jefe de la unidad de VIH,
and
hepatitis,
with
tuberculosis
hepatite
e
and
infecciones de
TB,
transmisión sexual en países
sexually
multipolares,
transmitted diseases as well, in
en
impacts
la
as well,
OPS. Hoy es asesor principal
in PAHO,
de participación
and
de la
we have
sociedad
this
civil en la
participation of the
eliminación de
civil
las
society
enfermedades transmisibles de la OPS o
for
IMSS.
PAHO.
Bienvenido, doctor.
And
Muchísimas
just
gracias por
welcome.
darnos
Thank you
este
so
espacio
much,
para compartir
everyone.
sobre
Thank you so much for
COVID
joining us
en el
today.
transcurso de la voz. ¿Podemos,
And
por
well,
favor,
yes, we'll pass the floor to you. Can we please just really get in touch with the doctor, please? Thank you.
Muchas gracias y buenas
Thank you
tardes
so
a
much. Have a good
los
afternoon,
colegas que están
everyone.
en
I would like to
esta
greet all of the colleagues
reunión.
who are here today in
Afortunadamente
this
me pude conectar
meeting.
para escuchar
I really got the
la
chance to
presentación de
really
la
listen to the
doctora
presentation
Velosa,
of
con lo
Dr.
cual
Veloso, which
siento
was
que hay
great, and I feel that there's
un buen inicio y una
a
buena base
great
para
beginning, a
lo que
great,
voy a pretender
just
decir.
really start for what I'm about to
Muchas
present.
veces
So, thank you very
tenemos la
much. I
fortuna
will
de
introduce some
tener
data,
muchos números, pero
very, very
siempre es
quick
un
data,
poco
so that I will
la
start
importancia o la
introducing the
posibilidad de que se
importance and the
puede
possibility to
reproducir
see
esto.
HIV as a
La región
problem
de
of
América tiene
public
HIV
health in Latin
y
America and the
debido a
Caribbean,
apoyo de la
including the
población
participation of civil
tiene algo
society, which
que
is
se puede hablar de
something that I'm
riesgo
responsible for
altamente
quite a while in the
sé que esto
PAHO.
tiene ya
I
una
know
repercusión
this morning we had
no
the
solo
inauguration
aquí en
of the
Latin
event.
America,
There
sino
were
que
people from the
a nivel
office in
global.
Mexico, so I thank you for this.
Para empezar,
To
podemos
start
ver
with, we can
que la
see
epidemia
that the epidemic
en las
of
últimas estimaciones del 2021
HIV by the end of
habíamos comentado de casi
2021
4
had
millones
around
de
4 million
VIH,
people living with
8 millones en
HIV,
América Latina y el Caribe
2.5 in Latin America and the
y
Caribbean,
una reducción de las
and
muertes
a
mortales de
decrease in the yearly
35%
death of
respecto al
about
2020. Sin
35%
embargo,
in comparison to
en el
2010.
2022
But in
estamos trabajando un poco
2022, we had a
diferente,
different
posiblemente
image,
dado
possibly
el
related to the pandemic
COVID-19.
by COVID
Vemos
19.
cómo en la región de América
We
Latina
see in the
hubo un
Latin American
aumento
region there
de
was a moment of
1,9% de los casos nuevos.
7.5% of new
Por supuesto,
cases.
no en todos los
Of course,
países,
not in all
sino
countries, but
en
of
algunos
course in some
países también
countries,
medianos. Y
mid-sized
lo importante de
countries.
notar
And
este
the important
aumento
thing to
del
see here
8% de los casos
of
no
these
tuvo una
8% increase in the
correlación
cases,
directa
there
con
was a
los géneros.
differentiated
Un
increase regarding gender,
aumento del
an
17%
increase of
de los
17%
casos
of new cases
en hombres
in
jóvenes y
male
en
and
adolescentes
reduction of
de
14% of
HIV.
cases in females.
Vemos aquí
We
nuevamente
see
la
here
misma gráfica.
this very same graph.
Vemos cómo en
We
América Latina las
see
muertes
that in
han
Latin
reducido
America
menos
deaths have
en
been
comparación,
decreased
una cantidad
less,
casi no
like in the rest of the
para todo el
month,
mundo,
by
y
a third,
también
not a
muestran
half, like in the
bastante
rest of the
estamos
world. And in the case of new
bastante
cases,
rezagados en relación
we are very
a otros
far
países.
behind related to the rest of the countries in the
Y
world.
tal y como se ha
And
presentado
as just this has it has been
prácticamente
shown in several
seguidos
years,
los informes de las
consecutive
naciones,
years, in
pues no
UN
solo se
AIDS
caracterizan
real
por aumentar el número de
reports,
infecciones de
half
HIV
of these cases come with men
también
having sex with
vemos
men, and 6% with sex workers, and 29% with users and couples of the previously mentioned groups. So it is important to prioritize the actions that we have to eliminate HIV as a public health issue. We see that we are very far away from the goals of 2025, and we're not about to reach those goals at all. And but we see that there is an important amount of people under retroviral treatment, but very little progress regarding the reduction of new cases, maybe given as an impact of the COVID-19 epidemic. And we see here in this graph the way the increase is more evident in women, in men than in women. Well, to give further information, we see the prevalence by infection of HIV with men having sex with men, the data available between 2016 and 2022, and we see figures of 31% of Trinidad and Tobago and going to 12% in Mexico, 9% in Guatemala, and 1% in some Caribbean islands. But there's always a notably higher prevalence than that presented in the mentioned countries. We see this in trans women. The prevalences are even greater than in men that have sex with men, and there we see the countries where this has been related. As for the uses of condom, you have the reported use of condom, which is very high in some Caribbean islands, but we can also see that these reports come from 2013, and in more recent years, actually, the average is for the use of condoms is like 18%, and something similar for trans women. And for to make this more graphical, we have these statistics of men that have sex with men, and something that was reported by our previous speaker. But we see that in 2022, 11.2% of this population in Mexico had active syphilis. And it is important to talk about discrimination and stigma, and we see how in selected countries an important average of the population, key population, that are men that have sex with men, sex workers, or trans women, were denied the services of health in the last 12 years, 1 year, 12 months, 1 year, and then did not go to the health services due to this reason for the last year. So the situation of the cascade of attention to HIV in Latin America and the Caribbean had a little enhancement, but it's not as good as much as we would like. We have an 82% and now 85% of people that are aware of their condition, and we have a greater number of people that are under treatment and those that are virally suppressed. Unfortunately, we are still having a late diagnosis, which is important, and this is located around 30%, and these are people that are have less than 200 CD cells in the moment of diagnosis. But being optimistic, we have the essential factors that may help us to eliminate HIV as an issue of public health. There are biomedical interventions, structural ones, and behavioral ones also. And we see that the work of prevention and using PrEP is one of the most important interventions for this, as long as the immediate treatment and optimal treatment based upon a testing, innovating testing strategy. The work of prevention and attention would imply that those elevated risk populations would have an algorithm where people that are already infected should have been linked to effective treatment and then reach a viral suppression, and those of that very same population that have a very important risk of infection should be linked to prevention services that would include fight against stigma and discrimination, condom, and PrEP. And this would help us to have this population to remain negative, and some of the data that we have heard in the previous presentation. So for these, we have some policies that are paramount that should be passed and thought in the countries. One of those is the approval of self-testing of HIV. There we would see what the situation of each country in the region is, and the establishing of PrEP policies. We are good in the region in that regard. And the implementation of assisted notification of couples, which we have unequally developed it in the region. And we see an increase in the number of people in PrEP in the region. Most of these people are in Brazil, and 14,000 in the Caribbean, most of them in Haiti, and 470 in Latin America, most of them in Brazil. And there we see the figures for some of the countries that we have information from. As for the national policies, very quickly, the fast treatment in Latin America, we have it in several countries. In some countries, the policy of starting of the treatment in the very same day they are diagnosed. The OFA has an elimination strategy passed by the member states in 2019 that would pretend to eliminate more than 30 sexually transmitted diseases by 2030. There has been some victories, and the greatest victory has been the elimination of mother-child transmission of HIV and syphilis, starting in Cuba in 2015 and going to several other islands in the Caribbean in 2017, and in 2023, which is not in this slide, in Belize, which is a Caribbean country located in Central America near Mexico, Guatemala. And this is the list of diseases to be eliminated by 2030, and we see HIV/AIDS in the middle, in the middle column, and the initiative wants to suggest four lines of action: one of strengthening for the integration of health system and services focused on the person, another to strengthen systems of surveillance and information, to address the social and environmental factors of health, and financing of services. There are some innovations in this model that is being presented in 2019, such as the services based upon and directed by the community and self-diagnosis that we'll be describing later on. PrEP is a scientific advancement that gives greater opportunity to people in risk of HIV having the transmission chain, but stigma is something important for the adoption. And to talk about it, stigma of PrEP may have and may endanger PrEP, and it is important to support these people with this intervention so that they will be able to talk to their peers and to encourage them to similarly start PrEP. This is a study performed in a community clinic for gay men in Guatemala. For a long time ago, we've been talking about some interventions to go forward for the elimination of HIV, and the first of them was uh, immediate access to treatment after being diagnosed with HIV. And there have been several reports that tell us that if you offer PrEP to an important number of people under risk, and where we test a number of people and they are placed into under treatment, we're going to reduce the infection of HIV in the places where we perform this kind of actions. Four strategies may eliminate AIDS by 2030, which would be diagnosing HIV positive individuals as fast as possible, treat them, prevent new infections by using PrEP and PEP, and include communities for information, creation of demand, and furnishing services and treatment to these people. We have some important information. When acute infection, which is only 1% of all the HIV infections, is responsible for an important number of new infections because PrEP led by the community or at a more basic level of the health system has a greater demand, a greater growth, and a greater impact. And the key population also, even though it is a little bit more expensive, has a great benefit for finding new infections, either new infections or people that are under important risk to acquire HIV. WHO says that there is a no risk of sexual transmission of HIV when a person living with HIV with an undetectable viral load, if it has less than 1,000 copies per milliliter, this is the logo that you use. That Q equals U, which is indetectable and intransmissible. And here we have some references where this is evident. And now, by the same token, the declaration of HIV in 2021 countries acknowledge that retroviral treatment and the annihilation of sexual transmission are a key element for the response of HIV in the region, and this will allow us to eliminate HIV as a problem for the countries in the world by 2030. The participation of civil society is included in these documents, in both in the political declaration as well as in the outlines or guidelines of WHS, as well as the documents on universal health. What do we need so that civil society will participate in the elimination of HIV in the region? Well, first of all, being aware of the epidemic, the new infections, which populations happen this, and or what kind of sexual activity among the people with HIV, which of those are diagnosed late, and what does this produce, which are the consequences of infection of HIV in the most affected populations, which are the most beneficial, the benefited populations with PrEP. By knowing the data given by our previous speaker, where we had figures as 7% in Peru, and which would be the populations that would be more benefited with an early diagnosis, which they would also be aware of the benefit of interventions. What's the benefit of an early diagnosis and immediate treatment? Benefits of PrEP as for the health and autonomy of sexuality, and the bad consequences of the incidence of sexual transmission. But this is pointed as an opportunity of working with sexually transmitted infections that is not giving in the sanitary environments. We need to know other health needs of the affected populations, and we saw some of that information in the graphs about discriminations and avoiding health services due to stigma and discrimination. Also being aware of what are some of other the needs of the populations as for mental health, management of other diseases, anal health, and among others, which are needs that if we do not understand them, it would be not as attractive to have this kind of treatments and services. We need also we have unsatisfied social needs, or something like transportation to the unit of health. And these are some of the topics that are referred by the most affected populations by HIV when they are questioned about this. And finally, the participation and governance on the response of HIV at a local level, state, and national level. It's a strategy that has been important in some questions, like in Brazil, for example, where communities would participate in the elaboration of attention and prevention programs, their implementation, such as for generating demand and the evaluation of these programs. The epidemic may be analyzed, and this has been seen in several places, like, for example, Australia. There has been a decrease, which has been important, of new cases. Uh, as long as we have new interventions. And there you'll see that PrEP is mentioned in 2016. This year in the YASA meeting in Australia, we were saying that there were very little cases in Sydney due to the use of PrEP. In London is the very same situation. San Francisco, something pretty similar. Thailand as well. And in Canada, we've seen important advancements towards the elimination of HIV in men that have sex with men and users of injectable drugs. In Japan, we have strategies for the elimination of HIV in men that have sex with men, and we have had math models for that. And in the Netherlands, we calculate that PrEP is an intervention that has a great potential of eliminating HIV as health issue. Amsterdam has announced in the recent Jazz Congress that they detected very few HIV cases in the population last year. OFA has developed instruments to calculate the needs of PrEP in the countries, and this is the tool that we have, and it can be shared for those that wish to use it. What are the opportunities that we would have to go forward to the end of HIV as an issue of health, public health, work in big cities and make the elimination in these cities, focus on gay men, bisexual, and the men that have sex with men older than 50 years, see the strategies in other countries and apply it in the country and see if this is possible for other diseases and assess the impact of information couples. And I would finish my presentation by telling you that in the framework of the AIDS World Day, which is tomorrow, OFA talks about the importance of these communities, bisexual men, men that have sex with men, people that inject drugs, sex workers, and the couples of these populations. So I will let you with this uh, quote by Herman Barbosa, where he acknowledges and stimulates the participation of the civil society in the response to HIV. And in the environment of social security institutions, it would seem like the most logical thing to do, and the natural thing to do would be to work with the organization of sexual workers. But I would just leave the experiences that could have been established in social security institutions to the colleagues that have invited us to this session. I really thank you for your attentions, and I will be available for you if you have any questions. Thank you. Well, thank you very much, Dr. Mayorga. I will take a fantastic piece of information that it is possible to eliminate HIV pandemic by 2030. That gives us hope, and we'll work with this. I don't know if anybody here would have any question, any comment that you would like to make to Dr. Mayorga. Rene, may you please introduce yourself again? Can you hear me? Can you hear me? Yes, yes. Okay, very good. Well, the camera is not looking at me, but I will introduce myself. It's a pleasure to all of you. I am Rene. I'm from El Salvador, and I have a question for the speaker, colleague Ruben. I would like to know about the self-tests, if you have any statistical information related to the application of self-tests in the Central American region, and which has been the effectiveness level that we have had in the application of these self-tests. Yesterday, when we had the presentation by our colleague Diana from the Salvadorian Institute of Social Security, she was talking about statistics of coverage on the part of the ISS and the Ministry of Health. And then in El Salvador, even though it's a very small country, the size of the state of Hidalgo in here, that it is a very difficult country. So there are people that need service in regarding sexually transmitted diseases, like in the ranches or rural places. So I think that self tests are great because you do not necessarily need to go to the health center, which is the very first level that we have to go to, and it's very, very far from us. So self tests are great. So I would like to know if there are some information about the topic of self tests in Central America. Thank you. Okay, thank you very much, Rene. Indeed, I have no information about the impact of self tests, but I can tell you that there are some experiences of self tests in region. Dr. Veloso gave some figures about self tests in Brazil where they do it in the previous day and we send the result by WhatsApp, and then we have the prep and the following day. I know that in Guatemala they have run self tests mainly during the COVID pandemic, but I have no information. I know that there are institutions that are working under this topic in the Central American region, such as ICAP, but I will be glad to ask them so I can have more reliable data. But I can tell you that El Salvador has pretty good data on the HIV pandemic. A couple of days ago, I was taking a look at the El Salvador data, and the epidemic in the El Salvador has 4 6 men per every woman, and almost at all ages except for 40 and 49 and greater or older than 50. But El Salvador has advanced importantly in the response to HIV. They have reduced the number of new cases in the last years, and it is a country that would be very interesting and important to pilot, where if the government finds it useful, an initiative for the elimination of HIV is public health issue, because it seems that they are doing what it takes to do this, not in a long run. So I cannot give you an exact answer to your question, but I can actually retrieve the information from the people that have had initiatives with the support of the United States government in several countries in the region. Thank you very much. Thank you very much. Can you hear me? Yeah, okay. Any other question? No, no more questions. Well, I would like to tell you that we have our general secretary. Now I'll give him the floor to Professor Alvaro Velarca Hernandez. Thank you very much, Vane, and of course, thank you, my dear Ruben, by your excellent presentation. We would have loved you to be in person with us. We hope that next year we'll have your talk uh, live with us. But thank you very much. Thank you, and thanks to all the people with us. Thanks for all the data that you have shared, Ruben, and all those encouraging words to make a better effort to finish with the HIV infections in our continent. And just to finish, I would like to, even virtually, I would like to give you this certificate for our participants. So we will be sending you to Washington. Thank you very much, Ruben. So I don't know if you happen to have any comment, or maybe Dr. Mayorga would like to say something. Oh, he went away. He rushed away. Well, what can we do about it? Okay, then. Well, we'll continue here with free work. Since we are very uh, way behind, we have just finished here, and we'll have a little break for the change of work. See you later. Thank you.
be welcome to the last session of evaluation of investigation in the framework of the Second International HIV Congress. Hello, good morning. Welcome to this last evaluation day. We're going to evaluate oral works that were submitted in the Second International HIV Congress. To do this work, we will start with the submission of the work that was submitted for evaluation, results of microelimination of hepatitis C in persons living with HIV in IMSS Quintana Roo. Please go ahead, doctor. Thank you. Good afternoon. My name is Andy Prieto. I specialize in epidemiology. I have a master's degree in clinical research. Over these past days, we have been listening of what is the importance of the different countries. Hepatitis C with HIV. We have organizations and governments who increase the HIV goal to eliminate hepatitis C virus. The HIV and hepatitis C share the means of transmission. Therefore, HIV people are a priority group to apply a program to eradicate hepatitis C. Hepatitis C infection is the main cause of chronic liver affection and death caused by liver diseases all over the world. Quintana Roo has one of the highest, or if not the highest, HIV/AIDS disease load, and it is important to know what is the HIV and hepatitis C prevalence in people living with HIV. All of this with the purpose of implementing screening to identify them, treat them, and prevent complications of hepatitis C infection. The different speakers have been talking about the complications of hepatitis C, and hepatitis C is a disease that has been underdiagnosed, and we are diagnosing patients in an advanced stage when they are having this uncompensated fibrosis, and when we have the cirrhosis that is irreversible. We have screening in asymptomatic people, and less than 3% are detected when they are asymptomatic, and these are in blood banks. For that reason, there is importance in implementing this screening, and we're doing this in blank groups. Dr. Brenda Rios also talked about this hepatitis C as well. We have this screening has been implemented in 2020, and we started in Quintana Roo in 2019. And we just realized that there are no studies in the prevalence of hepatitis C in people living with HIV. In the UK, we know that 30 and 50% of people living with HIV have been co-infected with hepatitis C. In the Euros AIDS cohort, they have a prevalence of 23%, and people living with HIV, there are two main studies, one with 122 patients and 1,560 with prevalence of 61 and 63%. These are very high prevalences. The purpose of this study is to determine this hepatitis C in people living with HIV, and IMSS Quintana Roo, and the results of the microelimination program of the virus of hepatitis C. The methodology is an observational descriptive study conducted in people living with HIV who require assistance and HGC3 in Playa del Carmen as well. We began this study with the screening. We are training a screener who became an expert in the topic, and then they had this physicians treating HIV patients. For that reason, they were talking about just general aspects of hepatitis B in patients waiting for the doctor's visit, and they would be subjected to a test, and they would just reply to a questionnaire. We would do a quick test, have a quick test results that were submitted for a confirming test, and the viral load for hepatitis C. The cases that have been confirmed have been protocolized to get direct action antivirals. We were giving clinical follow up until the treatment was finished, and then a second intake of viral load after 2 weeks, and then the treatment could range from 12 to 8 weeks depending on the decision made by the treating physician. Results: we had a total of 4,736 screenings from 2019 to September 2023. Out of these 4,723 screenings, we confirmed that there was a viral load to 124 patients. Out of these 124, we started treatment with direct action antivirals, and we had 108. Out of those 108, 105 finished and completed the treatment, and out of this, 105 have 62 with post-treatment viral load. Out of these 62, we have 59 with an undetectable viral load, which is one of our main goals to eliminate this virus. What are the characteristics of the case as well? Hepatitis C. And these were studies as well, 49%, and they refer they had more than one sexual partner in over a year. And, and what really gets our attention, so we have 43%, and this also changes a lot in the population that has been studied, because studies on hepatitis C and risk factor in general population, and we have a transfusion background, and above 374 is above 90%, but with this population we found only 4%. Now this chart includes the cases that have been screened and confirmed on a yearly basis from 2019 to 2023. In 2019, we began really nicely. We screened 2,118. Out of these 13 were confirmed. In 2020, we screened also the pandemic, and we also suspended screening, and then we confirmed 12 patients. In 2021, we just started retaking screening. We had 611, we confirmed 31. In 2022, we recovered services, healthcare services, including screening. We had 93. We confirmed 38 out of this 93. In this year, we have had 1,938, and we have confirmed 30. And this has been very challenging because in our population and census of people living with HIV in Quintana Roo, this is a phenomenon of floating population. 80% work in tourism, and we depend on their affiliation or membership in high tourism seasons. Specifically, that's how we can cater those beneficiaries. And whenever we have a low season, then these patients are just go to the health department, and for this reason we have some patients lost. We confirmed how many began with a treatment. Out of a total of 124, 108 began, which is 87%. And the next chart, those that started with a treatment, how many finished? We have 97%. And out of those that finished treatments, how many had a viral load? We had 50%. This decreases a lot because whenever we finish treatment, they need to wait 12 weeks. We notice that there are some patients that cannot go back to that sample, so that we can just check whether the treatment was efficient or not. Out of the 62 patients that got this post-treatment viral load, we had 59 that have not been detected. So as you may see, in 2020 we had a patient with a treatment failure. In 2022 we had 2. Overall we had 3 that we studied and that finished their treatment with a treatment failure. So to conclude, uh, this infection of hepatitis C is also something that is going to help us just by treating them prevent cirrhosis, and this is going to help us just identify what is the landscape in people living with HIV in IMMS Quintana Roo. And we have this elimination programs. This prevalence of hepatitis C was higher than in the general Mexican population that we are referring to in a healthcare service in 1.38, and it is lower than what has been reported in other countries where we have identified less prevalence of people living with HIV. And we are just really highlighting the significance of really seeing people as a group of interest. And this is a screening that we are promoting with people living with HIV every 6 months. And also to talk about that as well, and we have been diagnosed as well. That's all. Thank you. So, Dr. Erandi, so now as well, we will proceed to these questions as part of our evaluator body. Good morning, everyone. Congratulations for that work that has been submitted. I have two questions. Basically, one of them is prevalence, which was high during the pandemic after the service recovery and compared against the first year where we started in 2019. In 2021, it was 40%, which is very high. And then we had less than 1%. Is there any sort of explanation that you could have just shared? And the other situation is, what is the explanation? Sorry, we cannot hear you. So I will repeat the question. My apologies for this inconvenience. So I was telling you that the prevalence that was found in patients that got a screen in pandemic and pre-pandemic years and service recovery, specifically service recovery, was higher even than in previous years, and pandemic it was higher than the first year where we started with the screening. So one of the questions as well, if whether there's an explanation about these results. And another question that we have is, so we know what is the very low prevalence, and this is relatively just really low. So whenever we were talking about prevalence as well, when we had screening in 2019, we were talking about sample size, which is diluted in 2020 and 2021. It is such a challenge. We diagnosed and also created a protocol. So we do have patients, like I said, that are going to lose screening, and we also stop confirming them. And we have patients who were confirmed with viral load, and they have other treatment that we could not start. So these dynamics of people with living with HIV who lose their, let's say, term or which treatment has not expired, that is what is going to lead us to dilute this prevalence for many years. But the reason why it increased was because of the sample size. We saw all of this screening because of this reason. Hi, doctor. Is there any other question? Hello, good afternoon. I think that we can hear you. So, congratulations for your work. There is no question that it is a study that shows a great effort. Prevalence is higher than what we see nationwide, and that means that we need to have a protocolization of the patient with this information. There is no question that this is very important. And also, the results that we see from this are based on the numbers and the way these numbers have behaved over the years. And just in order to diagnose a patient living with HIV and with a co-infection with hepatitis C needs to be to have the virus genotypified. And I don't know if you're doing that on a daily basis or consistently, and what is the protocol that you have to determine what is the hepatic dose. I know that these questions may be a little bit different from the purpose of the study, but it is important to understand that because they have a direct impact on what we call the undetectable viral load in patients with HIV and hepatitis C, and we know that they could be classified as part of that curing classification. Right, if we talk about genotypes before we get this, genotype was treatment. I was talking about 2012. After 2016, where we integrated these new antivirals, it was no longer needed to see what was going to be the type of genotype for that treatment. Any type of genotype would be highly efficient. We see in the bibliography a high efficacy. So we did not have any genotypes. And what else? Is there any other question? Yes, um, liver fibrosis. Well, as part of the protocol, we needed to have some elastography in Quintana Roo. We need to go to Merida as well, and we have modified our protocol just to treat elastography, ultrasound, and this is how we have been simplifying all of these. Patients took from 3 to 4 months after they had been diagnosed, and we have also simplified this treatment as well. We are asking for very basic tests and a liver UT. We have the GT, and we know that we are treating everything like that, and we need to have all of this fibrosis. I just want to just really finish everything that I have to do. So, just thinking about everything that we have been doing, and we have this service as well. I don't know if you still feel that these results are reliable or not. Secondly, why is it that in why is it that the group with HIV is the group of interest? We have these IV drugs or intranasal drugs as well. This is the type of things that we have been doing as well, and we still need to just report everything that is related to the hepatitis C virus, right? So these results are reliable, yes. We are doing this screening with a fast test. We're still having a confirming test with the viral load. This screening was not consistent because of the pandemic. A lot of healthcare services were suspended even though they were priority. And then we started with some of the questions that we were asking in Quintana Roo and that were not suspended. But screening in general has they have this indication that we could not do this. So now the last question. So the group of interest and the reason why we're doing this. This is very important because hepatitis C is a chronic disease and we call it a silent cold. It takes from 12 to 15 years to get symptoms. That means that you're going to get symptoms that are going to be developed, but you may not know that you're sick before you get cirrhosis. In an HIV patient, this cirrhosis may accelerate up to 9 years. So a lot of people would get sick faster, and given the importance that we are having this um, damage, liver damage as well, this is how we were focusing on. This is when we start with this early stage as well. Is there any other question? More questions from the auditorium or from the audience in general? So this is a microphone. Hello, I am part of the group of beneficiaries with HIV/AIDS, and I'm part of the experts who developed the guides for HIV and hepatitis C. First and foremost, congratulations. I think that these are the works that we have been requesting from the observatory, and we would also like to invite you to do these introductions and to just present this work at the observatory. This is highly relevant because this is what we're doing from this collegiate group to have extra information. And I have some comments on the subject. Let's bear in mind that today, even though ifinazepam is not a drug as such, in slang it is a way for people of sexual diversity do have a way to be somehow infected because it is an infection via IV to maximize sexual desire. So we would see the pills ground and taken that way. So it's not only drug users. Today we have other type of recreational drugs that are not really related to opioids, and they are part of the day-to-day community of the sexual diversity. This is something that also took place in the pandemic, and that's one of the reasons why, or the underlying causes of this crystal situation. And also, what happens whenever we do not see all of this information? We see treatment following people. If they leave Social Security will continue to keep that scheme, and then AIDS is going to pay for that treatment for Social Security. Why? So that people do not lose their treatment. If they get or not their Social Security, what is it that we have been doing for this service so that at all times the person, regardless of where they are, and if there's complexity in the state of Quintana Roo, since these are mobile actions, specifically because we were talking about whether low or high seasons, and since this is a floating population as well, we have Social Security, so we may lose them because this is the type of mobility that we have. Specifically, we have this um, situations. We need to see how is the treatment going to follow the person wherever that person needs to go. And I think that it is also very important to note that today we need to start just really going towards doing other type of micro eliminations, specifically with the population of people living with hemophilia or people living with HIV or risk factors, people with diabetes type 2. This has been the main challenge. In other populations, there are some associated risk factors as well for hepatitis C. All of that is very important as well.
A very important point is sexual education, because they are populations that are, they're called, they are in constant risk. So within the consultation, we give them some advice. So this is why I ask them that they screen themselves on a monthly basis, because they might have eliminated the virus, but there might be a reinfection due to the sexual infection risk behavior is still there. So we see this with PrEP. They do PrEP, but they increase the other sexually transmitted infections. They do not have AIDS, but they have had an increase in the sexually transmitted diseases because they do not wear a condom. And to ensure elimination, we give complete treatment from the very beginning. For the hepatitis C virus, treatment, it might be 8 week or 12-week treatment, but making sure that they may have this issue. They give the three packages to the patients. Whether they are beneficiaries or not, they will know how to take this treatment. We have not been able to have this link. We are working with the Ministry of Health. When they are referred to Capacit, they will tell them, well, he's having a hepatitis C treatment, and we need you to tell us what his viral load is after the treatment. But at least the treatment is ensured, is delivered from the beginning. They receive their complete boxes. And I don't remember what was the last question, but yeah, considering the fact that they may have a loss of uh, what we do not have is a follow-up, because the patient went to the Ministry of Health, but at least we gave him the complete treatment. He went to IMSS Bienestar. Yeah, we are going to start with IMSS Bienestar in Quintana Roo. All right. Well, you've answered the question that I had indeed, because my point is about communication and coordinated or articulated work that you have between IMSS and the Ministry of Health. Because I am from El Salvador, my name is El Salvador, and I live in Hidalgo state, and it seems that they are completely different worlds and they do not have any communication at all, not even for so basic topics like PrEP when you go to the from capacity to IMSS or vice versa. So the infectologist opens it, you see it, and then gets it to the envelope again. That's it. So, what's the process of communication and work that you have with the Ministry of Health? It is paramount your comment, because in 2019 we opened the hepatitis clinic in Quintana Roo, because in the past patients would go to Merida, and then this was actually a problem because the Ministry of Health had these antivirals in the second half of 2020. In the past, they didn't have this, so this is why we would make sure to give complete treatments, because even if they went to Capacit, we would start, and the Ministry of Health did not have these medications yet. Due to agreements with the jurisdictions at the state level with the Ministry of Health, we are trying to have this link so that we will tell, well, this patient is not longer a beneficiary, but we're giving this complete follow-up. But when the patient is not more a beneficiary, we refer him to Capacit, and we give them a summary so that by the time he goes to Capacit, they will be aware of what kind of treatment he is going through. Something that worries me is that from the observatory, with the thought of this process, and I speak it in the first person because we fight to guarantee that this access would be in social security. And from the observatory, what we've done is that we're getting rid of these obstacles, but communication factor doesn't come from upwards, downwards, but it is important for you to be with us, me personally with Dr. Daniel Perez, to have you there, because it talks to us about the work that we have to do to link all these processes that have been already established in agreements and none that are not coming to you, that are working on a daily basis. So I think this is something pretty important that we have to do. I am representing the people that have been already cured and we lived with HIV and hepatitis C. We are working with this process. So the fact that you have no communication with them, it means that we need to work a lot so that this part of vinculation would be possible. And I will give further information. We have just had a very complex case in social security where the person fights against his couple, and the couple takes all his medication, including the hepatitis C, and they didn't know what to do in order to guarantee the continuity of the treatment. So we need to start looking at all these processes that today can be affecting the person that is under treatment of hepatitis C. Okay, it is a pleasure. Thank you for inviting me. Of course, I will do. So please, a round of applause for Dr. Arandi, please. Now we have our second work presented in this journey of evaluation that is entitled Activation of TCD4 lymphocytes associated with the suboptimal consumption of vitamin E, copper, and omega 3 with people having HIV retroviral therapy. Hello, how are you? Good afternoon. Thank you for your introduction. My name is Edgar Barrientos, and I'm going to talk about the previously described work. As part of the introduction, we have that the antiretroviral treatment has an effect which is extending the life expectation of people living with HIV. By 2023, we have 29 million people under antiretroviral treatment. This allows us to observe them in older ages. We've been describing metabolic diseases or alterations that are mainly described or are found to generally related to age, but they can be found in people living with HIV. The nutritional status is related to progression of the disease and inflammatory state of the individual and comorbidities during the treatment. This is why for this work we are caring for the dietetic consumption that can be classified as optimal, suboptimal, or excessive consumption. Optimal consumption is determined or established by recommendations, international recommendations, and the suboptimal consumption does not meet the recommendations that were generated according to health and sex and age. We have 195 countries for 27 countries and 255 early deaths. And on the graphs, even though they are a little bit far, it marks regions in the world, and the colored graphs indicate the amount of consumption. The green line is the ideal consumption. Most of the countries are under consumption of fruit, vegetables, which are the graphs that we can see, and for omega 3. The purpose of the work was to determine the prevalence of suboptimal of nutrients and associated with immunological and uh, the methodology was considering men older than 18 years with non-detectable as an exclusion criteria, the multivitamin consumption or any kind of supplementation. The work was made in the Respiratory Institute for respiratory diseases. Then we recruited the food where we quantified the consumption of magnesium, vitamin E, A, and lipid acids. It was reviewed by specialists, and it was placed in an informatic system, food processor, and we quantified the amount of consumption, and we categorized as a suboptimal consumption according to international recommendation the consumption of the participants according to what we see in the screen. To each and every one of the participants, we had a dual absorptiometry where we obtained the fat level, and we had a sample of blood to determine glucose, cholesterol, LDL, triglycerides, viral load, among others. So this was classified in metabolic alterations, and the immunologic markers assessed was interleukin 6, TNF alpha, and TTC4 and DBC8. The statistical analysis that we considered was a nutrimental consumption used as suboptimal consumption and as an analysis strategy to calculate the data of this consumption with models of logistic regressions is reported already with intervals of confidence of 95% to assess some sort of dyslipidemia. And regarding the other model used was a linear regression for immunological markers and assess the concentration of interleukin 6 and TNF alpha. Among others, we used the statistical program. We considered a 0.05 as a meaningful one. All models were adjusted by diagrams to direct the cyclicals, like years of diagnosis, years of HIV treatment, age, consumption of drugs or alcohol, among others. The results was 72 men with a mid-age average, an average age of 37 years of age. Generally, the participants related 80% of alcohol consumption, 37 tobacco, and 9% drug consumption. As for the prevalences of consumption, if we take a look at according to the international recommendations, only copper is that would reach the goal. But when we see our graph of suboptimal and optimal consumption, we can see that those that are in orange, we have four micronutrients evaluated below 50%. According to what we can see, Ensanud, which is our reference, relates the suboptimal consumption of magnesium and vitamin E. Vitamin E is 60%. Our population is 15 percentile points above the population recruited for Ensanud. And our data would be reporting three times more the suboptimal consumption. What happens with the other authors? Well, unfortunately for copper, data stay in year 2000, and for vitamin E and A, the span is too wide. So this data coming to this. So we have to keep in mind that during all these years, the antiretroviral treatment has changed, and then of course everything has been changing. By 2019, the United States, in a survey similar to in Sanuds, they derived the people that living with HIV has a greater nutritional requirement, and it can be seen in the use of energy that these participants have. Only a group of study has focused on evaluating omega-3 as a strategy for the rescue of the population, but we have a 50% below, we're a 50% below. As a conclusion, I will finish the prevalence of suboptimal consumption of magnesium and vitamin E. Another important piece of the information of our studies that we had biochemical determination. The most prevalent one was the alteration in cholesterol LDL. Once categorized, obesity is more prevalent with a 50%, 57%. And an important piece of information is that 45% of the population, that is to say, that our group of study had two metabolic alterations, which would be LDL and LDL cholesterol. The clinical differences, there were no differences according to clinical background. Only a group was a little bit more, seemed to be more older. So the association of nutrimental consumption with metabolic alterations was not important when already were assessed. But when we have the assessment of nutrimental and immunological markers, we saw the activation percentage was three times greater in people that have a lower consumption than recommended. And when we had the regression models, copper, vitamin A, E, and lipid acids had a significant increase with the beta coefficient. What I try to say is the suboptimal consumption copper, vitamin E, and lipid acids has a great action in cell actions CD4 and CD8. So the disease is going to last for a lifetime in the individual, and so this brings cell activation and an inflammatory process that has been described with mortality. It is important to have an intervention in nutrition in order to establish some recommendations for this kind of population so that we will restore or regulate their immunological status and enhance their quality of life. As a conclusion, those are the ones that I was mentioning little by little to optimize time, and that would be it. Thank you very much, Doctor. A big round of applause for Doctor. Questions for our evaluating panel or evaluation panel? Thank you. Good afternoon. Congratulations, Doctor. It is a doctor that reflects a lot of effort, work, and interventions of the variables. Is paramount and pretty interesting. Some questions on your method, the measurement of consumption. Maybe I didn't understand pretty well. Was it uniform in all the patients that were there? Which is the average time where you had the measurement of the consumption of food? How did you homogenize between all the participants? And an inflammatory status with HIV patients is associated with cytosines and many other variables. So, from what I can see, there was no result to be multivariate. Which importantly, thank you. In nutritional epidemiology, there are several tools to evaluate diet. One of these is a food diary. It is a diary that considers 3 days. It goes with the participants. They fill in all the consumption, the things that they consume. We consider all food that he consumes. We have all the consumption or the kind of food, the method of preparation, and it's placed in the system. In nutritional epidemiology, there is a certain kind of questions about this kind of tools, but from these tools, we've been able to create some guides because that's the most objective approach for the diet to the diet of the person. As I said, this includes 3 days, 2 days in the week, and one day on the weekend. And as for the other question, due to time issues, I didn't talk about the results of the models with interleukins. Actually, the interleukin levels are still controversial. So this is why I used mentioned activation data. A couple of questions, doctor. And compared to other studies, if there are in Mexico, besides this, what's the difference that you found? And if you can go deeper of the population that you included in the study? Well, that's a very good question regarding other studies performed in Mexico. Happily, despite all the time with the diseases, the very first work that evaluates the nutrition of participants. Even the study in the United States in 2019, even though they have more tools to have these kind of assessments, is the very first work where they evaluate the nutrition level for HIV patients, and this is where recommendation starts. And we need specific attention to these populations given the nutrition requirements that are different from the regular population because they require a greater consumption of proteins and calories for antibodies, and they have even proposed some kind of diet linked to the state of inflammation. So that was the purpose to assess that in Mexico, in this population, we do not have this kind of study. And as for your other comment, these 72 people belong to a work that they went into a follow-up group. It was a transversal study where we assessed the population. Yeah, it's 72 subjects that go to the Instituto Nacional de Enfermedades Respiratorias. All of them live here and they come in Mexico City. 72 people come and get you their antiretroviral treatment, and this is where we recruited them. Good afternoon, and congratulations for your work. And just to, regarding the study population and the results, I don't remember if in the whether in the factors that were considered for your analysis, the confusion factors or to adjust in the regression models, did you consider the time of evolution of the disease and of course the treatment time that could have had any effect? Yeah, for all models we consider both time frames the diagnosis time was the evidence that we had for traceability that they had a positive test, the first positive test that they used to be informed that they were infected with HIV, and the considered time for the models. Thank you very much. Any other question or comment from our public here? Well, if no more questions, please a round of applause for our speaker. And that's the way we have finished the assessment of the presentation of our research work. So I will allow me to thank our expert panel and assessors that we had today, whose knowledge in epidemiology, infectology, and public health was pretty important. So I would kindly ask a round of applause for Dr. Margot Gonzalez, Dr. Daniel Octavio Pacheco Rosas, and Dr. Antonio Leon Sevilla, Reina Sevilla. Sorry. All of them are part of the Unit of Innovation and Planning in Health and the Unit of Medical Attention from the Institute. So, this is our end of our streaming. We invite you to participate with us at 3:40 for our awarding and closing ceremony. Thank you very much.